and then we should be through the obstetrics and the gynecology. Okay, first, I want to make sure you can hear me all right. All right, can you hear me? Yeah? All right, good. All right, let's start with some cases, and I'm going to work through this thinking out loud, and let's see what you remember. Take out your handout, and you use it to work through. The first one we're going to do is female urinary incontinence. So here we start. A 45-year-old woman, gravida 5, para 4, AB1, complains of involuntary urine loss. Okay, that's going to be the issue that we want to deal with. Involuntary urine loss. She was diagnosed with type 2 diabetes 10 years ago and is on anti-hyperglycemic agents. So what do we know? What should be our next step in management? If you refer to the handout sheet, you'll see we want to start with, we want to get a voided diary, urinalysis and cultures, outpatient antibiotics, cystoscopy, or Kegel's exercises. Let me first tell you this. Is this going to be a clinical or a laboratory diagnosis? Urinary incontinence. What do you think? Can we make a diagnosis just by looking at what we've got here? It's partially clinical and partially laboratory. There's information that we need. What do we need first? Now notice here, this is the little black box. Voiding diary, do we have that? Is the urinalysis normal? No white cells, no red cells, no bacteria. Does the incontinence occur at night or all the time? Is there abnormal cystometry? And is there continual leakage? These are the questions that we want to answer as we go through. So when we start out, the first thing we want to do is to get a voiding diary. Now, we want to get a urinalysis as well, but you really need to get a history first. Now, you can get a retrospective history, or you can get a prospective diary, which is really ideal. But this is what I would put down for our start. Obtain a voiding diary over 3 days. We've talked about that before. Okay, so what do we find out? The incontinence occurs with coughing, sneezing, and running, but never occurs at night. What do you think? Where are we going with this? What does this sound like? This sounds like stress incontinence. I agree. She denies urgency, frequency, or dysuria. The first thing you want to do, however, is to make sure that you don't have something which is irritating the bladder. How are you going to find out what that is? Let's get a urinalysis and culture. What does it cost for urinalysis? It's cheapy cheap. What we're going to look for is in there any white cells, any bacteria, any red blood cells. And if all those are missing, which they shouldn't be there, then we can rule out a irritated incontinence. So let's see what we get. Now, Kegel exercises, you could make an argument, why not do Kegel exercises on everybody? Well, I guess that's true. Maybe I would benefit from Kegels, maybe you would benefit from Kegels, but that's not a specific one. I would start with the urinalysis and culture. So let's see what that shows us. Okay, the urinalysis shows bacteria and white blood cells, no red blood cells. Urine culture is positive with over 100,000 colonies of E. coli. What's our diagnosis? Well, this is a UTI, right? I mean, this is a UTI. A UTI is a laboratory diagnosis. We've got the laboratory test. I would go with oral outpatient antibiotics. Now, some people would say, well, this is not true urinary incontinence, a cystitis. Well, and that becomes a matter of definition of terms. But you need to think in your brain, is there something going on in the bladder? And that can be easily ruled out with a urinalysis. Okay, let's change this just a little bit. The urinalysis shows no bacteria, no white cells, but does show abundant red blood cells. Why is there microscopic hematuria? What is in the bladder which is bleeding from. The urine culture is negative. The only way you can know this is and see what is there. Is there a tumor? Is there a foreign body? Is there stones? That kind of stuff. Okay, urinalysis shows no bacteria, no white cells, no red blood cells. Urine culture is negative. All right, what would you want to do now? The history looks consistent with a stress incontinence. So you could go with Kegels exercises. Would you want to do, well, we've already got a urine diary. We've done a urinalysis. We don't need antibiotics. We don't need cystoscopy. The only one that makes any sense is Kegel exercises. Are you with me on that? Now, one could ask, would there be a benefit for cystometry? And I think that there might be in this situation. But if it's mild urinary incontinence and Kegel exercises are without any risks, you're going to have to read the case if they give you cystometrics. But on someone like this, you may not go through a full workup. Cystometry. Okay, let's say she's got severe involuntary urine loss. Urinalysis is negative, the culture is negative. In other words, it's not being helped by Kegel exercises. If it is involuntary urine loss because of stress incontinence, what is the pathophysiology? We have a loss of support of the bladder neck of the proximal urethra, so we need to, where's my hand? We need to lift it up. What's the surgical procedure for lifting it up? A urethropexy. And there's many different ways of doing that. You can do a Marshall-Marchetti-Kranz. You could do a Birch procedure, or you could do the transobturator vaginal tape, right? So there's a variety of different methods that you could use for this. And you're not going to be expected to differentiate between all of these because that's a resident level question. Okay, let's move on to a different case. This is a woman with moderate involuntary urine loss. The incontinence occurs day and night with, and here is the key word, urgency. Urgency, okay? When she's got to go, she's got to go. No dysuria, urinalysis, no bacteria, no white cells, no red cells, urine culture is negative. So even though she's got urgency, she doesn't have a cystitis. And this looks like, oh, and also cystometry is normal, and there are involuntary bladder contractions. This sounds like, it looks like, it smells like, it feels like a hypertonic bladder, detrusor dysmenorrhea, itty bitty bladder, and we have an overactive cholinergic system. How about anticholinergics? Okay, you got that. Let's see. That makes the most sense here. Remember, it is the parasympathetic nervous system, which the cholinergics, which contract the bladder. So what we want to do is to relax it. What are the side effects of anticholinergics? Dry as a bone, wild as a hare, red as a beet. You remember that? So dry mouth, all that kind of stuff. These are some of the side effects. All right, let's move on. We have moderate involuntary incontinence. The incontinence occurs day and night without urgency or dysuria. Urinalysis shows no bacteria, no red cells, no white cells. Urine culture is negative, but cystometry shows a residual volume of 800. There is your key right there. When you have a high residual volume, what is it that's going on? This is your hypotonic. This is your neurogenic bladder that doesn't know it's full, doesn't know it needs to empty. So we want to stimulate the bladder. What do we want to stimulate? What do you want to use for your management here? Kegels, urethropexy, anticholinergics, cholinergic, surgical repair. And this looks to me like D, cholinergics. Bifenacol would be a good one, Denise. All right. So what we want to do is we want to contract the bladder. Could you relax the bladder neck with alpha antagonists? Those would be also involved in there. So which one would you prefer? I think I would go with the cholinergics to begin with. Okay, the next one, moderate involuntary urine loss. 2 months ago, she underwent a radical hysterectomy for invasive cervical cancer stage 2. When you've got a history of radical pelvic surgery, anterior resection of the colon, radical hysterectomy, if you've had radiation therapy, you need to think about a fistula. What is the key historical finding with a fistula? The incontinence occurs continually, and I've got that in red here. Continually, without urgency or frequency. Urinalysis shows no bacteria, no white cells, no red cells. Urine culture is negative. Cystometry is normal. This sounds like a fistula. Do we know where the fistula is? I don't know where it is yet. How are we going to find it? Intravenous pyelogram. So this would be putting in dye, which is seen on your x-ray. It will show you where is the dye coming out of and where is it flowing into. So we need to identify the location before we can fix it. What do we find? IVP shows a vesicovaginal fistula. Is this medical or surgical management? A fistula is always going to be surgical management, and we'll go with an E. Okay, that pretty well takes us through the urinary incontinence. I think you should do pretty well on the exam with the information that I gave you on the handout. Okay, next one is vaginal discharge. And remember, we're thinking here of a bacterial vaginosis, we're thinking of a trichomoniasis, we're thinking of yeast, or we're thinking of a physiologic. All right. So here we start out. A 31-year-old Hispanic woman, gravid 2, para 1, AB1, complains of a fishy odor with vaginal discharge for 2 weeks. What is your main phrase that catches your attention here? Fishy odor. What does that sound like? Fishy odor looks like a bacterial vaginosis. She's on diuretics for chronic hypertension, diagnosed 4 years ago. Probably has nothing to do with what the process going on is. Her one child was delivered by cesarean 8 years ago. That's probably irrelevant information as well. So what do we want to look at? Why do I have this black box with a vaginal discharge? This needs to be taken away. Anyway, is vaginal discharge going to be a laboratory or a clinical diagnosis? It's a clinical. I mean, it's a laboratory diagnosis. Now, we're going to do a physical exam. We need to do a pelvic exam. We need to get some vaginal discharge. We need to put it onto a glass slide and look. So I would start with speculum exam, vaginal pH, and wet mount. And you really need to do all of these. I don't think they're going to ask you to divide that up and say do one versus the other. But clearly you need to do a speculum exam first, which will then give you access to the vaginal discharge. That's where you can use your nitrazine paper to check the pH, and we can put it on a glass slide. So this is where we're going to start. What do we find? Speculum exam shows a thin gray discharge. That sounds like a bacterial vaginosis. The pH is 6.5. Is that normal or elevated? pH of 6.5 is elevated. Is that consistent with a bacterial vaginosis? Yes. The only one that has a normal pH is going to be a physiologic discharge or a yeast. There is no edema, there is no erythema, there is no pain. Does this seem like an itis or an osis? Seems like no trichomonads, no yeast, but there are epithelial cells with fuzzy borders. What do we call those epithelial cells with fuzzy borders? Clue cells. Clue cells. When you look at what the criteria for diagnosing bacterial vaginosis, you've got the positive amine sign, the fishy odor, you have clue cells, and you have a pH which is elevated. This one, we've got a clear evidence of a bacterial vaginosis, and what is your treatment for bacterial vaginosis? It's going to be metronidazole. And I think I would go with the oral medication here. It is systemic. You only have one, well, actually, you probably need to give, no, a single dose should do it. A single dose should do it for bacterial vaginosis. Okay, let's change the scenario. Speculum exam shows a green, frothy, foul-smelling discharge with a pH of 6.5. Again, we've got an elevated pH. That's going to be consistent with bacterial vaginosis and trichomoniasis. Her vagina is red and swollen and tender to touch. Is that an itis or an osis? That's an itis. Microscopic evaluation with saline shows motile organisms, the flagellated trichomoniasis, and that's probably what we got here. What is the treatment for trichomoniasis? Metronidazole. Orally. A single dose, 2 grams, should do it. Is this a sexually transmitted disease or is it not a sexually transmitted disease? It is a sexually transmitted disease, so her sexual partner also should be treated. Yes. Okay, let's change the scenario a little bit more. Speculum exam shows a white cottage cheese discharge. What does a cottage cheese discharge sound like? That sounds like a yeast, right? A candida infection. The pH is normal. Is that consistent with a yeast? Yes, it is. Her vagina is red and swollen and tender to touch. Is that consistent with an itis? Yes. Microscopic evaluation with potassium hydroxide shows hyphae on the slide. This all is consistent with a yeast infection. The treatment for a yeast infection, what is it? Metronidazole, azole creams, fluconazole, or either C and D, and the answer would be E, both C and D. And you can make arguments for one versus the other. There is not a standard of care that says one is better than the other. You kind of play it according to what the question sounds like. The fluconazole, the benefit is you have a single dose. It is high compliance. The azole cream is immediately applied. So on the exam, they probably will not give you both. This is just for my instructive purposes here. Okay, how are we doing? Are these helpful for your brain? Jawohl, das ist gut. Ja. Okay, vulvar lesions. 52-year-old woman complains of a pruritic right vulvar lesion for the past 6 months. She had a total vaginal hysterectomy 5 years ago for uterine prolapse. Probably has nothing to do with the vulvar lesion. The exam shows a 5 by 10 millimeter firm white lesion on the right labium majora. What is it? Do you know what it is? I don't know what it is. Could it be benign? Yes. Could it be premalignant? Yes. Could it be malignant? Yes, it could. The only way you can identify what an unknown lesion is with a punch biopsy. And that could be done in the office, very simple, a local anesthetic. And you're done. What did the punch biopsy show? Hypoplastic dystrophy. Another word for this is squamous hyperplasia. What is the treatment for squamous hyperplasia? For hypoplastic dystrophy, it is fluorinated corticosteroids, and that's really all you need to know. Let's look at this, a little different case. The exam shows a 5 by 10 millimeter atrophic bluish white lesion on the right labium minora. When it is atrophic, sometimes discussed as parchment-like, what are you thinking of? A lichen sclerosus? No. Is this a laboratory or a clinical diagnosis? It is a laboratory diagnosis. Let's get a punch biopsy. Let's get a punch biopsy. Send it to the pathologist. The pathologist sends you back the report. And what do they say? It is, in fact, lichen sclerosus. What do you treat lichen sclerosus with? Clobetasol cream. You got it. Very good. Next exam shows multiple 5 by 10 millimeter reddish lesions on the right labium minora. Originally, it was whitish, and then it was thin, and now it's reddish. What is it? I don't know what it is. How are you going to find out? Punch biopsy. Have I made my point? Any lesion of unknown origin needs a biopsy. What does it show? Partial thickness, vulvar intraepithelial neoplasia 2. So this is a premalignant lesion. What are you going to do when you got a vulvar dysplasia? We're going to take it off. You can usually use surgical excision. See, you can use surgical excision in the office. If you're going to do laser, that's got to be done in the operating room, and that's going to be much more expensive. So if you have a single lesion, I would just do a surgical excision. You could inject local anesthetic, and you can do that very easily. Less expensive. Okay, here we've got same patient, but she's got multiple 5 by 10 firm lesions on the right labium minora. There are multiple. There are many of them. In this case, I think we need, well, do you want to treat it or do you want to know what it is first? I don't even know what it is yet. We need to start with a punch biopsy. And let's see, the diagnosis is vulvar carcinoma in situ. So this is full thickness. So when there are multiple lesions, I think you're better off to go to the OR and to do a laser vaporization. And when you do laser vaporization, you need to have a scavenger set up which will aspirate or suck up the air, because when you vaporize these lesions, you could get HPV, which you aspirate and suck into your lungs. You don't want to do that. The laser is not to be preferred because it is more expensive, but if you have a multifocal, many lesions, it may be easier. You know, you're going to have to read the question. I just want you to get the idea. With multiple lesions all over the vulva, you're probably better off to do it in the OR and to use a vaporization. Okay, what if the biopsy shows squamous cell carcinoma with 3 millimeters of invasion? Whenever you've got invasion, you've got carcinoma. And the next thing you've got to do is to do a staging. And when you stage vulvar cancer, it's got to be done surgically. So we're going to have to do radical vulvectomy and inguinal node dissection. And on the exam, they will not give you an answer which involves 2. They're going to be much better in writing their questions than I am. But you get the idea. When you've got invasion, you've got to do staging. And staging involves assessment of the nodes and the radical vulvectomy. Okay, muy bien. Next, we look at abnormal pap smear. 18-year-old woman comes to the outpatient clinic for contraceptive planning. She is sexually active with a single partner, currently uses a diaphragm. She requests a pap smear. How old is she? 18. What is the age at which you start pap smears? Age 21. Are we going to do a pap smear? No, because even if you find something, you're not going to do anything about it. Come back in 3 years. Are you with me on that? Now, if she has HIV, if she is immunosuppressed, different story. But if she is a garden variety, no risk factors, come back in 3 years. Okay, let's change the scenario just a little bit. She is now 20 years old and she's have a pap smear. Again, don't do it. The standard of care is to wait until she is 21 and then you say come back in a year. So the whole idea is the only time you're going to do something is if it's going to change your management, unless it is for academic purposes, if you're doing a study of some kind, in which case you need to get a patient informed consent. Okay, she now comes in and she's 21 and she wants a pap smear. What procedure will you do? Only cytological screening of the T-zone, only HPV DNA typing, do both of them, or do you go directly to colposcopies and biopsies? When she's 21, the recommendation is not to do the HPV, so all we will do is the cytology. And the reason is if there is HPV, even if you find it, it's going to probably be spontaneously removed by the immune system. So just do the cytology. What does the cytology show? Negative for intraepithelial lesion or malignancy. That's what you wanted to see, was negative. So now what do? How often do we repeat the pap smear on a woman who is 21? Every 3 years. From age 21 up to age 30, 29 to 30. Okay, let's change the scenario just a little bit. Instead of being 21, it's a 31-year-old woman comes for a pap smear. What procedure will you do on her? What are the recommendations for the procedure between age 30 and 65? And it is C. It is the combined cytology, which is the scraping of the superficial surface cells, and the HPV DNA. That's what you're going to do if she is 30 to 65. So let's do it and see what we find. We do it and it comes back negative for intraepithelial lesion or malignancy. The HPV DNA typing is negative for high-risk types. So are we happy with that? Yes. How often do we repeat this? If she's between age 30 and 65, we'll repeat it in 5 years. That's a huge change from what we did just a few years ago. But what they're trying to do is to minimize the invasive procedures on young women. Okay, let's change the scenario. Well, actually, let's come back. What if she was 31 and all we did was the cytology? We didn't do the HPV. The cytology comes back negative for intraepithelial lesion. Then how often would you repeat? And you guys are right on. It would be in every 3 years. So the 5 years is only if you have the combined cytology and the HPV. Okay, 66-year-old woman comes to the outpatient clinic. What? She's coming for contraceptive planning? She doesn't need contraception at age 66. I need to change that. Okay, anyway, she wants a pap smear. What would you do to a 66-year-old woman? Does she need a pap smear? No. As long as she's had normal pap smears over the previous 10 years. She doesn't need it, you can stop it. So age 65 or greater, no further pap smears needed. If she's had a total hysterectomy with the cervix gone and the corpus of the uterus, she doesn't need it either, unless the hysterectomy was done for CIN. Okay, the 22-year-old woman comes in. She had the pap smear, and it comes back ascus, atypical squamous cells of unknown significance. What are the recommendations if we have a 22-year-old woman who has ascus? This is the mildest change. It is the mildest change, and so what we want to do is to just repeat it. Or we could do the HPV DNA typing. But these are both non-invasive procedures. Are you with me on that? You can go whichever one you want. But this is not the primary test. This is a follow-up. Let's say she is 32 and she comes back with an ascus. The recommendations there are exactly the same. You can either repeat the pap smear in 12 months or do the HPV DNA typing. And either one is appropriate. All right, change the scenario. The 22-year-old comes back and has LSIL. Is this a severe or a mild finding on the pap smear? This is not severe. The severe is going to be ASK-H or HSIL. The ASCUS and LSIL are going to be on the mild end. So here we want to do a non-invasive procedure, and the recommendations are to repeat the PAP in 12 months with the LSIL. What if she was 32? If she was over 25 years of age, that's when you would go ahead and do the HPV DNA typing. Now, let's go on to the next one, which is ASK-H. ASK-H is atypical squamous cells, cannot rule out high-grade lesion. We don't know. This looks like it's heading toward HSIL, but it doesn't quite meet the criteria. But this is more concerning. So on a 22-year-old, on a 30-year-old, we would do colposcopies and biopsies. And the same thing, if she was 30 and we got an ASK-H, we're also going to do colposcopy and biopsies. That's going to be the same regardless of age. But if we have HSIL, which is the most severe abnormality next to cancer, if she's 20, we want to go ahead and do the colposcopies and biopsies. But if she is over 25, then we could do the colposcopies, but recommendation is to go to the immediate leap. Cut out the transformation zone. And this pretty well summarizes what was on the figure on the bottom of the page, that table that I gave. Okay, 26-year-old woman underwent cervical pap smear, and the cytology came back cancer. Now, that's kind of unusual. I probably should change the age and put this more like a 45. Would that be better? I think I'm going to do that next time. But if the cytology comes back cancer, you're going to need to do colposcopy and biopsies. Because you need to find out, has it invaded the basement membrane? How far? Is it less than 3? Is it 3 to 5? Or is it over 5 millimeters? Okay, colposcopy was unsatisfactory. Unsatisfactory colposcopy can be because there is metaplasia, normal appearing epithelium going in the canal, or it could be an abnormal epithelium which is going into the canal. And what we find here is metaplastic epithelium going into the canal. If you have metaplastic epithelium, what is our intervention? And it's going to be endocervical curettage. Minimally risky. All you want to know is there abnormalities in the canal? But this is metaplasia. Let's, when we do the endocervical curettage, the result comes back normal epithelium. What do we do now? We need to repeat in 3 years. But let's say that the endocervical curettage shows an abnormality, specifically CIN. Now what do you want to do? I would want to do a cone biopsy, narrow and deep, because I want to make sure that the margins are clear and that it hasn't invaded. So if you have the metaplastic epithelium going into the canal, we want to do the endocervical curettage. If it is a positive endocervical curettage, then we need to follow up with a narrow and deep cone biopsy. All right, let's change, or when we do the cone biopsy, we find it is CIN 2, which means that the basement membrane has not been broken, and there are clear surgical margins. Are we done? Are we done at this point? Yes, but we need to follow up and make sure it doesn't return. So I would do repeat pap smears every 3 to 6 months for 2 years. For 2 years. Okay, colposcopy was unsatisfactory due to a white lesion entering the endocervical canal. This is different. This is not the benign metaplastic epithelium. This is abnormal epithelium. In this case, we need to go straight to a narrow and deep cone biopsy. Narrow and deep cone biopsy. Cone biopsy comes back, SIN2 with clear surgical margins. Okay, let's follow up every 3 to 6 months for 2 years. Make sure that it is all gone. Okay, colposcopy was satisfactory. We could see all around the endocervical canal, no lesions, no metaplastic tissue going in. But on the exocervix, we see mosaicism and punctation. If you have exocervix, which shows that we need to take that off with a biopsy, and so we would do an ectocervical biopsy. Ectocervical biopsy. What does that come back showing? It shows SIN2. All right, we talked about how many options do you have with SIN1, how many options do you have with SIN2, and how many do you have with SIN3? If it was SIN1, how many options do we have? 3, which is observation, ablation, or excision. With SIN2 and 3, there's 2, and that is going to be excision or ablation. So it's going to be either the LEAP or the cryotherapy. And if I had my choice, I would do the LEAP because you've got a specimen that you can send. All right. And that should pretty well take care of the pap smears. Okay, postmenopausal bleeding. Our big concern is endometrial carcinoma. 62-year-old woman complains of painless vaginal bleeding for the past 3 weeks. Menopause was at age 53, so she is 9 years postmenopause. She was diagnosed with type 2 diabetes 5 years ago. Next step in management. If you have vaginal bleeding, regardless of what the age, you need to first start with a speculum exam. You always start with a speculum exam. Speculum exam shows a bleeding cervical polyp. What are you going to do? We've already talked about that. Let's take it out, a cervical polypectomy. That would explain it. We have a diagnosis. We don't need to do anything further. Let's say the speculum exam is unremarkable. No lesions. So there's no vaginal lesions. There's no cervical lesions. So there is no explanation from the lower genital tract. Now we've got to identify, is there something in the upper reproductive tract, which is up in the uterus? What procedure would you do? The best one, the cheapest one, the one that is done in the office is an endometrial biopsy. And I showed you how to do that. It is a blind way of doing it. You just put the instrument in the canal and you rotate around and you aspirate. The endometrial biopsy shows endometrial atrophy. What is your management for endometrial atrophy? This doesn't have enough estrogen. That's why it's bleeding. So we're going to go ahead and give her some estrogen, but because she has a uterus, we also need to give progestin. Atrophy is treated with estrogen, but you need to give the progestin anytime you give estrogen. Now, what do you think this woman's BMI is? You think it's 25, 35, or 45? If she's got endometrial atrophy, most likely it's going to be 25. It's going to be low. Okay, let's say we do an endometrial biopsy and it comes back normal endometrium. There is no hyperplasia. There is no atrophy. What now should we do? If we cannot find it with an endometrial sampling, now we need to look and see if there is a localized lesion. And this would be done with hysteroscopy. Hysteroscopy shows endometrial polyps, so let's take them out. Hysteroscopic polypectomy, and that's easy and simple to do. She shows simple hyperplasia without atypia. What is the likelihood of simple hyperplasia without atypia becoming malignant? Is it high or low? Low. Should we use medical management or surgical management for simple hyperplasia without atypia? Medical management, let's go with oral progestin, MPA, medroxyprogesterone acetate. Give that for 10 days each month. In 3 to 6 months, repeat the biopsy. Okay, endometrial biopsy shows complex hyperplasia with atypia. Is this premalignant? Yes or no? And the answer would be yes. Would you want to do surgical or medical management when you've got a premalignant lesion? I would want to do surgical management. Let's take out the uterus. Now, would you take out the tubes and the ovaries as well? You know, it kind of depends on the situation. The minimal procedure would be TAH. I think the tendency nowadays is not to take out the ovaries unless they are abnormal. But we talked yesterday about tubal carcinoma causing serous cancer of the ovary. So anyway, right now I would say a TAH. Okay. Now, what would be the reason? Let me just answer Repka, that if she had endometrial carcinoma, you would want to do a TAH-BSO. But because this is not carcinoma, it is pre-malignant, you really don't need to take out the tubes and the ovaries. That's the reason for that. But what if the endometrial biopsy showed endometrial carcinoma? That's when you would do the TAH-BSO. On the exam, they don't want you to be excessively aggressive. You want to be prudent, but not overzealous. Okay, then these will be the last questions, and then we'll go on to chapter 6. So, Steve, after this, we will. Oh, actually, why don't we go on to 6, and we can maybe see the video clips after the break. Okay, premenopausal mass. A 22-year-old woman is seen for contraceptive planning. A routine pelvic exam reveals a midline, non-tender, mobile pelvic mass. Woman in the reproductive years. Pelvic mass. What's the first thing you want to rule out? Pregnancy. Thank you very much. Beta-HCG. But doctor, I have never had sex. Next step in management, beta-HCG. Qualitative serum beta-HCG test, negative. Is she pregnant? No. Are you sure? Yes. A negative beta-HCG tells you you do not have functioning trophoblastic tissue. What's the next step? Sonogram. Remember, with a premenopausal pelvic mass, first beta-HCG, second is sonogram. We want to know on the sonogram, is it a simple cyst? Is it a complex mass? Is it a solid mass? Because the only way you can say it might be functional is if it's a simple cyst. So let's do the sonogram. The sonogram shows a 5 by 5 centimeter simple adnexal mass. Fluid-filled, no septations, no calcifications. Most likely explanation is a functional physiologic cyst. It could be a follicular cyst. It could be a corpus luteum cyst. If you watch it, it'll go away on its own. Let's just watch it. Let's just watch it. So we'll repeat the ultrasound in 6 to 8 weeks. We repeat the ultrasound in 6 weeks, it's gone. Our working diagnosis is a functional cyst. What do you want to do now? Do we need to do anything else? No, we're done. It's a retrospective diagnosis if the mass disappears that it was probably a functional cyst. What if on repeat sonogram in 6 weeks it shows a persistent adnexal mass? See, if it remains there, it cannot be a functional mass because functional masses will go, whether they're small, whether they're big. We need to go in there. Is this malignant? Probably not. So let's do a minimally invasive procedure. We'll do laparoscopy. Pelvic sonogram shows a 5 by 5 centimeter complex adnexal mass. Could this be a functional cyst? No. If it is complex, it cannot be. Now you need to figure out, does it look like it's more likely benign? Could it be malignant? If it's malignant, we want to do a staging laparotomy. If it is benign, we do a laparoscopy. I would think we would probably do the laparoscopy, but you're going to have to read the question and figure out, are they giving you hints suggesting that it could be malignant? What's the most common benign complex adnexal mass in a young woman? A dermoid. Yeah, a dermoid. Pelvic sonogram shows a 5 by 5 centimeter solid adnexal mass. What's the likelihood of a solid mass being functional? Zero. Zero. Nothing. We're going to have to go after this. What could it be? The most common malignancy, a solid malignancy in a young woman, is a dysgerminoma. I think I might lean to a laparotomy. But again, you're going to have... Now, Jose asked, can you resex a dermoid with laparoscopy? Absolutely. If you are well trained, which you should be if you're going to do the procedure. Yeah, you just take off the dermoid part, you leave the normal ovary right there. Okay, 22-year-old woman seen in the emergency department, severe right-sided pelvic pain, pelvic exam, 8 by 9 centimeter marked, tender, mobile right adnexal mass. Beta HCG is negative. What are you concerned with? Torsion, right? Torsion. What do you need to do? You want to get in there quickly or slowly? I would say quickly. I would want to do a laparotomy because I want to preserve that ovary and make sure it's not going to get twisted. Okay. Postmenopausal mass. I guess we should do this one too because we got to this. All right, let's look at... No questions. Okay, Steve, let's go with the gestational trophoblastic disease. I need to make up some questions for postmenopausal pelvic mass. Okay, the next one is gestational trophoblastic neoplasia. GTN. Here's our case. A 24-year-old Filipino nurse. Why do I pick on the Filipinos? Because molar pregnancy is 10 times more common in the Philippines and in Taiwan. 10 times. In the United States, 1 per 1,000 pregnancies. In the Philippines and in Taiwan, 1 in 100. Why? I don't know. So she's 14 weeks by date, but she complains of vaginal bleeding as well as severe nausea and vomiting. Her uterus is up to her umbilicus. How many weeks is a uterus of the umbilicus? That's 20. And she's only 14 weeks. So we have a uterus larger than dates, nausea and vomiting, vaginal bleeding, no fetal heart tones, which you should be able to hear fetal heart tones if there's a fetus at 20 weeks, right? Unless she's 350 pounds. Blood pressure is elevated, 150 over 95. A urine dipstick shows proteinuria. So it looks like we've got preeclampsia at 14 weeks. That is possible with molar pregnancy. And so when you see that on the exam, it should ring a bell, it should wave a flag in your brain. The most common symptom of molar pregnancy is early pregnancy bleeding. And the nausea and vomiting kind of supports that. So this is an artist's conception of these avascular villi of a complete mole which fill up the uterus completely. And there is no placenta, but you can see there is no fetus. These are villi which are floating in saline. And you can see how a woman could say, I passed some grapes through my vagina. Because these kind of look like white grapes. All right, let's look at our handout. We're going to look at a benign and malignant. The benign can be a complete mole or an incomplete mole. Malignant could be good prognosis, poor prognosis. So let's start right here with clinical findings. Vaginal bleeding. That's the most common finding with early pregnancy. With a molar pregnancy, early pregnancy bleeding. So this is going to be something which is in your differential anytime you have early pregnancy bleeding. Passage of grapes, that would certainly suggest this. Severe nausea and vomiting, you think of a molar pregnancy. No fetal heart tones when you've got a uterus up to umbilicus. Uterus larger than dates. If you have very high levels of beta-HCG, it can stimulate the formation of bilateral theca-lutein cysts. I showed you pictures of that yesterday. And preeclampsia before 20 weeks. All of these would suggest that you've got a molar pregnancy. However, what do you do from a physical standpoint and an imaging? Obviously, you want to do a spectrum exam anytime you have early pregnancy bleeding. Is there a lower genital tract lesion? Is there a vaginal lesion? Is there a cervical lesion? Then we want to do a sonogram. What would the sonogram show if it was a complete mole? It would show a snowstorm pattern. I'll show you what that looks like. The older ultrasounds, it looked like a big blur snowstorm. Nowadays, we can actually see the vesicles. But there's no fetus or amniotic fluid, and there are diffuse homogeneous echoes. I'll show you that. That will give you the diagnosis. But what it doesn't tell you is if it's benign or if it is malignant. The only way you can know if it's benign or malignant is to go to the operating room and take it out. But pre-surgically, we want to get a number of studies. We want to get a beta-HCG titer. Is this going to be urine or is it going to be serum? If you want to get a titer, it's got to be serum because you can't do titer on the urine. Because what we want to do is to find out how high is the titer, and then once we remove all of the uterine contents, it should come down and down and down and down. So we need to use this as a handle to follow up our successful management. Chest X-ray, lung metastasis. The most common distant metastasis with a molar pregnancy is in the lungs. And then we can lose a lot of blood, so we want to do a type and cross match. Okay, we go to the operating room. What procedure do we do to empty the uterus? It's going to be a suction D&C. We send that to the pathologist. The pathologist will then tell us what the histology is. Is it benign or is it malignant? If it's benign, it could be a complete mole. This is a 46XX, no fetus. This is paternally derived X's. 20% risk of recurrence, so we need to do follow-up for 1 year. And we'll look at the follow-up in just a minute. It could be an incomplete mole. This is less likely. Incomplete moles are 69XXY, a dispermic fertilization of a normal egg. There is a little bit lower chance of recurrence, but it is still significant, so we need to do follow-up for 1 year. And that's going to be beta-HCG titers. If it is malignant, it could be either good prognosis or poor prognosis. And this kind of sounds like an oxymoron. How can you have a good cancer? Well, this is the best cancer to have. It is the incomplete mole which can have a fetus. Notice, over 95% cure, and to make it easy to remember, metastasis to the pelvis or lung is good prognosis. Single agent chemotherapy, typically methotrexate, and we follow up with beta-HCG titers for 1 year. Poor prognosis, that's pretty good cure also, 65%. But if you'd remember, this is metastasis to the liver or the brain, multiple agent chemotherapy, and follow up for 5 years. Okay, the follow-up. All patients, whether they're benign or whether they're malignant, should have contraception, effective contraception. And more likely, we're going to give oral contraceptive pills. Although you could give the estrogen progestin patch, you give the estrogen progestin vaginal ring. Now, all patients then will get serum beta-HCG titers weekly until they become negative, and then they will have it monthly for 1 year if it's complete mole, 1 year if it is incomplete mole, 1 year if it is a good prognosis malignancy, and for 5 years if it is a poor prognosis. Okay, this is in your book on page 198. The complete mole arises from an empty egg, the incomplete from a normal egg. The complete mole is paternal X's only, the incomplete is maternal and paternal. So we got a 46XX, and these are both paternally derived. They are both from sperm. They're 2X sperm. And here we have a 69XXY triploidy. This fetus, there is none. This fetus is non-viable. So there's no fetus with a complete, 20% chance of going on to malignancy, 10% with the incomplete. We already talked about that. No chemotherapy, but we want to do serial beta-HCG titers weekly until negative, and then follow up for monthly titers on oral contraceptives for 1 year. When we look at the malignant, it could be either non-metastatic, good prognosis, or poor prognosis. Non-metastatic is the uterus only. The good prognosis is the pelvis or lung. The poor prognosis is the brain or liver. Remember these. Pelvis or lung, good. Brain or liver, poor. 100% cure. That's very good. I mean, can you get better than 100%? 95% with good prognosis, 65% with poor prognosis. Single agent chemotherapy here, multiple agent chemotherapy. This is probably going to be outpatient. This is inpatient. The risk of significant immunosuppression is not high with single agent, but it is much more with a multiple agent. 1 year follow-up with good prognosis or non-metastatic, 5-year follow-up with monthly beta-HCGs. The reason we use the contraception is because we don't know if the titers start going up, if it is that coming from a normal pregnancy or if it is from a recurrence. So the longer the period of time since the DNC and the beta-HCG stays down, the more confident you are that it's not going to come back. And after 1 year, we feel confident enough to say you can go ahead and get pregnant with non-metastatic or good prognosis, but with poor prognosis, 5 years. 5 years. So, is it, if it's non-metastatic, is it cancer? Sure. You can have localized or you can have metastatic, but it's still cancer. Okay, this is on page 199. We want to do beta-HCG titers before we do the DNC, so we have a baseline for future comparison. We want to get a chest X-ray for lung metastasis to rule that out. Then we go to the operating room and do a DNC. We empty uterine contents. I'll show you that in just a minute. And we already talked about the oral contraceptives for 1 year if it is benign, and if it is good prognosis, 5 years if it is poor prognosis. So this is the triploidy incomplete mole, 69XXY. Here you see the 3 pronuclei. Each of these have 23 chromosomes. This is what the snowstorm would look like. This is an ultrasound from 1998. So it's about 15 years old. The newer ones that we have are much better. This is an incomplete mole. It doesn't have the snowstorm. In fact, it has a fetus. And this is the skull of a 69XXY fetus. We talked about fecal lutein cysts you can have if you have very high levels of beta-HCG. This is not uncommon with a molar pregnancy. Here is a lung metastasis. You can see the coin lesion over here. Here's another coin lesion. And these will disappear with chemotherapy. They're very responsive. This is obviously a woman who died. This is the metastasis to the brain. Poor prognosis. Here we're doing a DNC. Let me show you a case that we actually had. This is a patient who is under general anesthesia. You can see the tube is in here. But have you ever seen a uterus that looks like this? It's not the usual elongated uterus. This is like as if she swallowed a basketball. And here we're getting ready to do the DNC. This is the suction curette that we use. This is the tubing that we will suck with. These are the curettes. These are the dilators right over here. So we have dilated the cervix. We have a tenaculum on the anterior lip. And here we are ready to put in the suction curette. So we put it in, and then we turn on the suction, and it starts pulling out all this blood and grunch. Grunch, kind of a non-medical word for debris. And here it is. How much blood do you think is in there? A lot of blood. That's why we type in cross-match. Now, let's take the blood away, and what do we have left? These are the avascular villi. You can see they look a little bit like grapes. Okay, these are 69XXY non-viable fetuses. All right, here we're looking at serial beta-HCG titers. And you can see they're coming down and down and down. And less than 5 is considered 0. So how many weekly titers do we need to do before it becomes negative? Here's 1, 2, 3, 4, 5, 6, 7, 8, 9. So 2 to 3 months. This is what we call the decay curve, if there's no more beta-HCG being produced. Now, what if the titer comes down initially and then starts leveling off and then starts rising? Now you've got to be concerned about a recurrence, right? Or metastasis. So now we need to give a second round. Well, first I want to do an ultrasound to see, is there a normal pregnancy in the uterus, which is causing this, or is there a recurrence of the disease? And if there's recurrence, then we need to go with chemotherapy. Okay, why don't we take our first break, and we'll see you back in 10 minutes. Okay, here we are for our second hour. I wanted to show you yesterday some video clips, and I'm not sure if you saw them yesterday. I didn't see them, but let's go with the first one. These are all on leiomyomas. Okay, here you can see the ovary on this side. These are the subserous leiomyomas right over here, right there. See, this is the uterus here, and this is your subserous. This is what makes the uterus feel lumpy and bumpy. Okay. Okay, let's go on to the next one, Steve, if we can. All right, these are going to be larger. Actually, there's one large leiomyoma right here, and it's about the same size as the uterus. So this is the uterus, and this is the leiomyoma. I mean, it's about the same size as the uterus. This is subserosal. Subserosal. These probably isn't big enough to cause any symptoms, but you would certainly see it when you did the ultrasound. Okay, let's go on to the third one, which is the bleeding one. Okay, this is an intrauterine, a submucosal. And can you see the hemorrhage? Can you see how it is so reddish? Now, this is a tubal ostia on this here. But this is an example of a bleeding submucous leiomyoma. It's a pretty good size one. It almost fills the entire cavity. Okay, let's put the last one on, Steve. And this is a cool video clip because it shows a hysteroscopic resection. In the olden days, this patient would have had a hysterectomy. All right, let's see if we can make it. Here we go. Okay, it almost fills the entire cavity. Now here we are with this loop. Can you see? It's kind of like doing a leap with a hot wire. And here we're taking another chunk. And let's take one more. See, and by doing this sequentially, you can remove the whole thing. It's kind of like a transurethral resection of a prostate, a little bit like that. Okay, and I think we're done with that, Steve, so we can go on now to the next chapter. Now, did you see these videos last night at all? Yesterday evening? No. Okay, because I didn't see them either. Okay, that's what I thought. Okay, let's go on now to chapter 7. Okay, 7 is STDs, sexually transmitted diseases. This is an interesting poster. It was used during the Second World War by the military to encourage the soldiers not to get infected. She may look clean, but pickups, good time girls, prostitutes spread syphilis and gonorrhea. You can't beat the Axis. The Axis represented Japan and Germany and Russia. If you get VD, they used at that time, it wasn't sexually transmitted disease, it was venereal diseases. What do you think of this one? Booby trap. I guess that kind of speaks for itself. This is interesting. These are German officers who are singing this song about the American soldiers. And this is their weapon. She is our sunshine, our only sunshine. She makes us happy through bombings blue. Though Russians rush us or Yankees crush us, she'll give the VD to you and you and you. Oh, I'm not much of a singer, but it's kind of clever. Okay. Where do we find the highest percentage of STDs in the world? Sub-Saharan Africa. That's not a surprise. 12%. Caribbean and Latin America, 7%. And then Southeast and South Asia, 5%. So geographically, that's where we find the most STDs. And here you can see that the darker the color, the higher the rate of STDs, excluding HIV. All right, this is an interesting one because it's looking at CDC data in 2013. What is the highest STDs by incidence? And incidence is number of new infections. And you should probably know this for the exam. HPV is the number 1, chlamydia number 2, trichomoniasis 3, gonorrhea is 4. That's in terms of incidence. And the numbers are incredible. 14 million, 2 million, 1 million, 800,000. Now, let's look at prevalence. Prevalence is a number of new and existing ones. HPV, again, is number 1, but herpes is number 2. Trichomoniasis is number 3. The difference is that HPV cannot be cured. Chlamydia can. Gonorrhea can, but herpes can't. That's why herpes comes up here in prevalence, because it's going to be there forever. If you have a new case, it'll never go away, whereas trichomoniasis, chlamydia, and gonorrhea can. Okay, we can divide STDs into STDs with ulcers and without ulcers. With ulcers, chancroid, granuloma inguinale, genital herpes, lymphogranuloma venereum, and syphilis. Those without ulcers, chlamydia, HPV, gonorrhea, hepatitis B, and HIV. Now we can further look at these in terms of painful and painless. Which are the painful ulcers? And it's going to be chancroid and genital herpes. Now, which of these two is the most common? Genital herpes. So that would be a good exam question. Of the ulcers which are painless, granuloma inguinale, LGV, syphilis. Which is the most common of those? And it will be syphilis. The rest of these are uncommon. Chancroid is uncommon, granuloma inguinale is uncommon, and LGV is uncommon in the US. Now, this is in your book on page 202, but let's look at this. See, this is on the top. Chancroid is painful, genital herpes is painful, granuloma inguinale, LGV, and syphilis are painless. Okay, STDs with ulcers. Herpes, we've already talked about. I don't think we need to go into that anymore. Syphilis, we've already talked about. And here we have a chancre. I don't think we need to talk about that anymore. Chancroid, we have not talked about. And let's just mention a few things that you should know. Number 1, chancroid is a cofactor for HIV transmission. Actually, the most honest statement would be that any genital ulcer is a cofactor for HIV transmission because the squamous epithelium is broken. And it is one of the 2 STDs that presents with a painful ulcer. The other is herpes. Where is chancroid more common? It's going to be in sub-Saharan Africa and Southeast Asia. And we already looked at how STDs are more common in those places. All right, this is an uncommon STD, chancroid. We already talked about it is painful along with herpes. Would you remember on the exam, if you see a description of a genital ulcer with a ragged edge, you should think chancroid. The CDC says the diagnosis is made by doing a culture, and the treatment is azithromycin. Why azithromycin? Because they said so. And you better answer that. That is the current thinking. Okay, do you see a ragged edge here? Do you see a ragged edge here? I guess I could call this a ragged edge. All right, LGV, lymphogranuloma venereum. Common or uncommon? This is uncommon. Is it painful or painless? It is painless. Would you remember for the exam? Groove sign. And I'll show you why it is a groove sign. The diagnosis, the CDC says, is by culture, and the treatment is doxycycline. The CDC recommends this. You don't need to know the dosage, you don't need to know the route, just that it's doxycycline. LGV, a rare infection, may surface in the US. A rare sexually transmitted disease that is spreading among gay and bisexual men in Europe could be poised to surface in the United States. The CDC urged doctors and clinics to be prepared to diagnose and treat gay and bisexual men with LGV. It issued the advice after receiving reports of recent outbreaks in the Netherlands. The Netherlands normally has only 5 cases a year, but now they've got almost 100. So it's rare. Here we see lymph node enlargement from LGV. This is clearly an itis. You can see it is swollen, it is red, it is probably tender. Now this is the groove sign. If you have a lymph node on either side of the inguinal ligament, the inguinal ligament will prevent it from rising up. So it goes on either side, creates a groove in between. Only 10 to 15% of patients have it, but you better know this for the exam. Groove sign, LGV. Granuloma inguinale used to be known as Donovanosis. A newer name is Klebsiella granulomatosis. Okay, where is it found? Sub-Saharan Africa, Southeast Asia, and Australia, and Latin America. Common or uncommon? Uncommon. Painless or painful? Painless. Would you remember beefy red? Beefy red. And the reason it's called granuloma is because the beefy red appearance suggests granulation tissue. The diagnosis is made by seeing Donovan bodies. I'll show you what that looks like. And the CDC, the treatment is doxycycline. Does this look like granulation tissue over here? I would say it could. This is your granuloma inguinale. You can see it looks different than chancroid, but I don't think they're going to show you a picture on the exam. Here is a lymphocyte, and these are the Donovan bodies in the lymphocyte. Okay, this I gave you in your handout. It's also in the notes, but I like this color better. Chancroid, painful, ragged, soft edge, inflamed. These are all STDs with ulcers. LGV, groove sign. Remember the groove sign. Granuloma inguinale, beefy red, and Donovan bodies. Syphilis, I showed you the picture before under the OB. Rolled, hard edge. Herpes, smooth edge, but inflamed. So the chancroid and the herpes are going to be painful. And this is basically the same thing, but I like the colors here better than this, but they didn't want to put colors in. So this is what you got in the book. Okay, STDs without genital ulcers. Condyloma acuminatum, chlamydia, gonorrhea, hepatitis B, and HIV. Let's look at condyloma acuminatum. Okay, HPV is a mediating organism. Common or uncommon? It is the most common of all STDs. Is it painful or painless? Well, actually, there are no symptoms at all. It is subclinical. Subclinical means it's there, but it doesn't have any symptoms. It has no pain, typically. Where is the most common location that you're going to find HPV? And it is on the cervix. You may see it on the cervix. Now, you may see it on the vulva, like I showed you pictures of. You can see it in the vagina as well. The diagnosis is visual. You don't need to biopsy it. The treatment, podophyllin, bichloroacetic acid, trichloroacetic acid. These have been the traditional treatments. These are doctor or clinician administered. What they do is they break the cell membrane, release the antigen into the circulation. The lymphocytes are then made aware of these particles. The lymphocytes will make antibodies, and they will get rid of the HPV. So it is really not burning it away. It is stimulating the immune system to clear it away. This does not need a biopsy. You can tell just by looking. This does not need a biopsy. You can tell by looking. Okay, this is on 203 in your book. The patient applied are Podophylax, imiquimod or Aldara, and there are new ones called cinecatechins, which is a green tea extract. The nice thing about these, they are patient applied, they do not cause pain. The provider administered, these need to be done by a physician or a physician assistant because they can burn. The podophyllin, the trichloroacetic acid, and the bichloroacetic acid. Now, cryotherapy and surgical removal would be done by a physician. This is your imiquimod. That's the the generic name. Aldara is the trade name. And it is basically, it is immune phase modulator. It stimulates the immune system to take care of the disease. So if a patient says, give me some antibiotics, give me some antivirals, there really is nothing. You need to stimulate the immune system. This is a fairly good sized condyloma. I mean, it's right over the anus. Can you imagine how much fun this must be? This is a pregnant woman. This is a cervix, and this is the condyloma. See that? I don't like this here. This fetus is going to come through the cervix, which has this HPV all over the place. And this is a concern about infecting. And it is found that fetuses or newborns delivered through an HPV-infected cervix do have a higher rate of laryngeal papillomatosis. It's not high, only 4 per 100,000. But you should know this for the exam. It is not a high enough frequency to justify a scheduled cesarean. Okay, we've already talked about trichomoniasis under vaginal discharge. I don't think we need to talk about that anymore. Chlamydia. This is a big issue. A quarter of U.S. sexually active 15 to 19-year-old females are chlamydia positive. I don't write all this down. I'm just trying to make a point. 80% don't even know they've got it. They're asymptomatic. 40% of them will get PID. We'll talk about that shortly. 20% will develop infertility. 20% will have chronic pain. And 10% will have ectopic pregnancy. And these are young women who are just becoming introduced to their reproductive life. It's the most common bacterial STD in women, chlamydia. Chlamydia does its dirty work by creating adhesions. And you can see all these adhesions here. Intracellular gram-negative bacteria, which cause adhesions, which can cause PID, which can cause infertility, which can cause pain. What business do young kids like this have engaging in sex? Oh, honey, I love you so much. Sure. One of the big risk factors is age less than 20. Age less than 20. And if you've got one STD, you should think of others. The adhesions can be in the uterus, can be in the tubes, can be in the pelvis. That's where they mostly do their dirty work. But they can also do it in the liver. I'll show you that shortly. Honey, baby, I love you, baby, baby. Sure. This is looking at 13,000 female Army recruits. And look at the prevalence of chlamydia. 17-year-olds are the highest. And as you get older and older, it's a direct line. By the time you get 30, it is a disease of young people. A disease of young people. 50% of STDs are found in teens and young adults, even though they make up only a quarter of the population. Let's look at the CDC data on chlamydia. Look at the rate in women and the rate in men. This is a sexually discriminating disease. Women are disproportionately affected. The gender ratio, 5 times more common in females than in males. And the highest rates are in females ages 15 to 24. 15 to 24. When you look at the histogram here, and this is looking at ages 10 to 14, 15 to 19, and so on. This is the rate in males. This is the rate in females. You can see women are far more impacted than are men with chlamydia. And the highest rates are 15 to 19, 20 to 24. Totally unfair. When you look at racial, ethnic numbers, the highest rate is in blacks, black women, American Indians, Alaska Natives, Hispanics, and then white and Pacific Islanders or Asians. So the highest are in black women, followed by Hispanic and American Indians. Minorities are disproportionately affected. Why? I'm not entirely sure. This is a newborn who has chlamydia of the eye. This is why we want to do cultures of women who are pregnant, and this is why we want to give eye drops, you can see here, to the newborn. You're going to see mucopurulent cervical discharge with chlamydia. It is a very common disease. It's the most common bacterial STD. It is most common silent. It has no symptoms. It has no pain. On physical exam, you will see mucopurulent cervical discharge. The diagnosis is made by PCR or DNA probe, and single dose of oral azithromycin will take care of chlamydial cervicitis. A single dose. What do you do for sexual partners? The woman comes home, says, honey, you need to be treated too. This is the California Health and Safety Code, chlamydia treatment of sexual partners. First choice, bring the partner in for evaluation, testing, and treatment. Ideally, give separate prescription for both patient and partners, but also acceptable to put both names on the prescription or state patient and partners as appropriate with the corresponding number of doses. You need to ask the woman, how many sexual partners do you have? And that's how many doses of azithromycin you give. You limit to the number of sexual partners in the last 60 days. This is somewhat unusual. We're treating a patient who we've never seen. But this is recommended. It's called expedited partner therapy. Expedited partner therapy. This is from the New England Journal of Medicine. Patient-delivered treatment for partners reduces gonorrhea and chlamydia rates. So that's what you should do for the partners. So chlamydia is a big issue. Gonorrhea is also, but not as prevalent as is chlamydia. Now this is interesting. Well, on the chlamydia, we had a Caucasian. With gonorrhea, we have a black woman. So all ethnic groups can be affected by STDs. Interesting. prior to antibiotics, gonorrhea was the most common disease of adult men. In 1900, in New York City, 80% of adult males had gonorrhea, and 20% had syphilis. That's amazing. That's amazing. We talk about the good old days. The good old days weren't so good old days. And there were no antibiotics. How would you treat gonorrhea or syphilis? Okay, gonorrhea. Common or uncommon? Relatively common. Is it painful or painless? If it is a cervicitis, it is silent and painless. On exam, you're going to see mucopurulent cervical discharge, similar to what you would see with chlamydia. The diagnosis is made by culture, and the treatment is cefixime and azithromycin. Let's talk about that. The cefixime is directed at gonorrhea. What is azithromycin for? The CDC recommends if you have a gonorrhea which is positive, you treat for both. So you give both cefixime and azithromycin. If your cervical cultures come back with only chlamydia, then you treat only chlamydia. This is looking at the histogram, gonorrhea in men on this side, gonorrhea in women on this side. Now this is far more symmetrical than the chlamydia, although even there, the 15 to 19-year-old women have far more chlamydia than do the males. So disproportionately, this is looking at ethnicity, Black women, American Indians, Asian Pacific Islanders, and whites. So again, we can see that we've got disproportionately affecting the minorities. Now let's talk about gonorrhea. It can affect the lower reproductive tract, the upper reproductive tract. The lower reproductive tract, Bartholin's abscess or cyst. I'll show you some pictures in just a minute. We're going to talk about PID coming up as well. Gonorrhea and chlamydia can cause PID, which is really better termed a salpingo-oophouritis. What's also interesting is that you can have disseminated gonorrhea. You can have endocarditis from gonorrhea. You can get septic arthritis from gonorrhea. When I was a medical student, I went to the emergency department with my intern, and a nice-looking young man with a effusion of his knee. We put a needle in, aspirated the effusion, did a gram stain, and what do you think we found? Intracellular, gram-negative diplococci. He had a gonorrheal septic arthritis. So it can be widespread in the appropriate situation. Now let's look at the Bartholin's glands. The Bartholin's glands are located here and here. Normally you can't feel them. The patient doesn't even know that they're there, but there are ducts which empty out over here. If we get gonorrhea of the Bartholin's gland, you can get an obstruction of the duct and you can get a Bartholin's abscess. Is this an itis or an osis? Mamma mia, this is an itis. You can be sure this patient is going to be uncomfortable. So what do you do for this? Historically, you could do a marsupialization, and this is in your book. And this is where you would make an incision and open the area up so it could drain. Make the incision and create a little pouch. You know, marsupials have pouches. So nowadays, the recommendation is not to do marsupialization, but to use a word catheter. And this is on page 204 in your book. You make a stab wound in the abscess. You take the catheter and put it inside. It has a bulb which you can inflate with water. And what it basically does, it creates a drainage tract. This is what it looks like. You make a stab wound, you put it in, and you let it drain. And once it has, so you're basically draining the abscess. Once it is drained, then you can deflate the balloon and take it out. Now, if you don't do anything to it, the abscess can be taken care of by the body's immune system. And here's where you have a Bartholin's cyst. So it's not infected, but it is fluid filled. And, it's got a mass effect, which doesn't feel good. And here is an artist drawing of a Bartholin's cyst. And you can see there's a little one right over here. And you can use a wart catheter for that as well. Now, this is ophthalmic gonorrhea, gonorrhea of the eye. Now, how would gonorrhea get to the eye? What kind of activities would do that? Well, this is what they call the fomites, right? The fingers go wherever they should, go up to the eye, and you can put it into the eye. Here again, you can see gonorrhea of the eye. You want to see gonorrhea of the eye of a newborn? Oh my, this don't look so good. This is why we want to use the silver nitrate to take care of this so that you don't see this in the newborns. Okay, and Steve, if you can get ready for chapter 8, which we'll be coming on to pretty quickly. This is an interesting story. This is Elizabeth Blackwell. Elizabeth Blackwell was the first woman to graduate from an American medical school, and that was in 1949. So she was 49, 18 years old at that time. They wouldn't let her practice in the United States because to be a doctor, you had to be a man. So she had to go to Europe to do an internship. She went and was irrigating the eye of a newborn with gonorrhea. It splashed up into her eye. She got gonorrhea of her eye. And of course, they had no antibiotics back then. They had to enucleate her eye and take it out. She wanted to be a surgeon. Would you like to have a one-eyed surgeon operating on you? So anyway, she never became a surgeon. But that's the story about Elizabeth Blackwell. Okay, to take a gonorrhea specimen, you need to get the cervix and also the anus. So we do a cervical and an anal culture, send it for diagnosis, cervical and rectal swabs. And we talked about this already. If you have a positive gonorrhea, you have dual therapy, cefixime, which is for the gonorrhea, and azithromycin for the chlamydia. Single oral dose, and that should do it. Now, gonorrhea is becoming resistant, and this is not good news. Quinolone-resistant gonococcal strains now in the world. And this is why the CDC, from time to time, changes the recommended treatment because the treatment that they had before is no longer good. These resistant organisms, they can kill you because you don't have any antibiotics which can do it. You're better off to have HIV than to have drug-resistant tuberculosis, for instance. So these antibiotic resistance, the CDC is very, very much concerned about that. Hepatitis B, we've already talked about. HIV, we've already talked about. Okay, I think that should do it for chapter 7. Let's go on to chapter 8. And chapter 8 is pelvic pain. Okay, pelvic pain. Do you think this is a common or uncommon in women? Pretty common. The answer, Sylvie, is 2. Okay, pelvic pain, if we can have that, Steve. Okay, here we go with pelvic pain. Prevalence of pelvic pain, 15% of women. That's a lot of women who have pelvic pain. We've talked about some of the causes of that already. One that we haven't talked about is pelvic inflammatory disease. Now, notice the ethnicity of this young woman, Asian. So what we have is PID, Asian, gonorrhea, black woman, chlamydia, white woman. What they're trying to show in these fact sheets is that all ethnic groups are involved. Okay, let's look at our case. 19-year-old, gravida 0. She may remain gravida 0 for the rest of her life if she gets adhesions. Presents to the emergency department with bilateral low abdominal pelvic pain for 24 hours. So this is acute onset of bilateral pain. A woman in the reproductive years, particularly younger, who has acute onset of bilateral pelvic pain, you better think PID. She just finished her menses. And it's interesting, PID is an ascending infection. It goes up into the cervix, up into the uterus, and is much more common right after the menstrual period. She is sexually active with no contraception. Speculum exam reveals mucopurulent cervical discharge. Mucopus. I showed you the frozen waterfall already. Pelvic exam shows bilateral adnexal tenderness and cervical motion tenderness. Okay, what is it that causes cervical motion tenderness? Now here I have a metal fetoscope. This is from Amsterdam. But let's assume that this is the uterus here, and this is the cervix down here. When you do cervical motion tenderness exam, you use your finger and you move the cervix like this. And can you see what happens up here when you move the cervix? It is going to tilt the uterus and it's going to put the fallopian tube on a stretch. It's going to stretch the fallopian tube, and if it is inflamed, it's going to be tender. So one of the findings of PID is cervical motion tenderness. Another diagnosis that can have cervical motion tenderness is ectopic pregnancy. Ectopic pregnancy. So if you see on the exam cervical motion tenderness, you better think PID, you better think ectopic pregnancy. Now she is afebrile. Urinary beta-HCG is negative. Always good to get a beta-HCG if you have pelvic pain in the reproductive years. And her CBC shows a white count of 14,000. That's elevated. And erythrocyte sedimentation rate is also elevated. So this is a classic story, classic picture of a PID. PID starts with a cervicitis. The bacteria go up into the uterus. They typically don't cause much of an endometritis. They then go into the fallopian tube, cause a salpingitis, the ovary, a salpingo-oophorytis. So, a cervicitis, minimal endometritis, acute salpingo-oophorytis, which I think is a better description of what PID is. Now, acute salpingo-oophorytis can go a number of ways. If you don't treat it and you have scar tissue as forms, it can become a chronic PID, or it can get worse and you have tubal ovarian abscesses. We'll talk about that. And this often can be present without significant symptoms, but causes morbidity. Now, this is in your book on page 209. Cervicitis can become acute salpingo-oophorytis. If we treat it properly, adequately, hopefully we will have a normal pelvis, no adhesions. But if it is inadequately or not treated, it can either become chronic PID with diffuse adhesions causing pain, or gets worse and becomes a tubal ovarian abscess. All right, let's look at our handout. It's a busy one. Let me cover it up and gradually we'll go through it. First thing, PID is a clinical diagnosis. It's by history and physical exam. There is not a specific laboratory test, and I'll talk about that why. It is an ascending infection, goes from the cervix up into the uterus, into the tubes and ovaries. So, salpingo-oophouritis is a better term. Oh, let me first go over here. Let's get a beta-HCG, because beta-HCG negative is going to rule out ectopic pregnancy. That's always going to be good to make sure that's not there. Ectopic pregnancy can be an imitator of a lot of things. Okay, the CDC, the Center for Disease Control, is so concerned about undertreatment of PID, resulting in significant long-term morbidity with infertility and pain, that they say that you can diagnose PID in the presence of the following, and this is all you need: pain, pelvic or lower abdominal pain. Now, that's a symptom that the patient tells you. Tenderness, either of the cervical, motion tenderness, palpation of the uterus, or the adnexa, in a sexually active woman with no other identified cause. So, if you've got pain, pelvis or abdominal, with tenderness in the pelvis, cervix, uterus, or adnexa, and no other explanation, that's it. That's it. Now, there are supportive criteria which would tend to give extra weight: fever, mucopurulent cervical or vaginal discharge, vaginal fluid leukocytes, elevated white count, elevated SED rate, elevated C-reactive protein, positive GC or chlamydia testing. But you don't need these. You don't wait for these. You go ahead and treat if only these are present. Now, cervicitis is different. It's low, it's just the cervix. But PID is upper tract. Okay, we want to get our cultures and our probes: gonococcus, chlamydia, HIV screening, any other STDs which you want to get. But we don't wait to treat. Now, there are 3 organ systems in the pelvis. We've already talked about that. The GI tract could cause appendicitis, diverticulosis, Crohn's disease, irritable bowel syndrome, urinary tract, cystitis, pyelonephritis, reproductive tract, ectopic pregnancy, torsion of the ovary, endometriosis, and we'll talk about this. So let's say we at least have passed these by our brains. But we're thinking it's a PID. Now, what do? It is a clinical diagnosis. All right. Now we need to identify, is it outpatient or inpatient treatment? Outpatient treatment criteria: absence of inpatient. Well, what are inpatient criteria? And here they are: high fever, nausea and vomiting, so she can't keep down oral medications. You got to go with IV. Outpatient treatment failure. You tried treatment as an outpatient, didn't work. Severe pain, needing narcotics. Unsure diagnosis. Is there something that's going to rupture? Or if you have tubal ovarian abscess. These would be inpatient criteria. But if we don't have a high fever, patient can keep oral medications down. You haven't treated outpatient previously. Pain is not severe. You're pretty sure of the diagnosis. There's no tubal ovarian abscess. Then you do outpatient treatment. Now, what do you treat for outpatient? Ceftriaxone, 250 milligrams IM, 1 dose. That's going to take care of the gonorrhea. Doxycycline, 100 milligrams, BID for 14 days. That should take care of the chlamydia. Then they say, with or without metronidazole. Now, frankly, that makes me very unsure. Why don't they say use it or don't use it? They say with or without. So I included this in here, and I think it would be reasonable to give metronidazole 500 milligrams BID for 14 days because they're concerned about anaerobes. Typically, anaerobes are secondary invaders, not chlamydia and gonorrhea, which are the primary invaders. So the anaerobes would be more likely but anyway, I would treat outpatient ceftriaxone, doxycycline, metronidazole. Okay, inpatient criteria, we just talked about that. And the CDC recommends cefotetan, 2 grams IV every 12 hours. That would be directed toward the gonorrhea. Doxycycline, 100 milligrams, and you can either get IV or PO. If she's able to take PO, then you use the PO. And we'll give that every 12 hours. And hopefully the fever will come down, the tenderness will go away, and we continue on for a total of 14 days. So that's the outpatient, the inpatient criteria, and what are the medications that you use, okay? So ceftriaxone in 1 dose and 14 days of doxycycline metronidazole. We're going to continue these only as long as she's in the hospital. But we want to give 14 days. Now, let's look here. What is chronic PID? Chronic PID is similar to acute PID, except that there are some differences. As with acute PID, there is pain. That's the symptom. As with acute PID, there is tenderness. But there's a normal white blood cell count, there's normal erythrocyte sedimentation rate, there's a normal C-reactive protein, there is no mucopurulent cervical discharge. What's going on? There's no infection, no active infection. What you do have is adhesions. There's adhesions. That's what's causing the pain and the tenderness. So how do you make the diagnosis? It's going to be by laparoscopy. It's a diagnostic laparoscopy. And when you get in there, if you find it, you can try to lyse the adhesions. Now, if the pain is so severe she can't function, you may need to do a pelvic cleanout. TAH, BSO on a young woman. On a young woman, that would be terrible. Don't give her narcotics because that'll be a lifelong thing and she'll get addicted. So this is a tough one to deal with. I'll show you some pictures after the break. The other possibility is that it could go on to a tubal gland abscess, TOA. This patient can be very septic, a negative lipstick sign, very high white count, very high sed rate. And on pelvic exam, you can feel fluctuant masses, or it may be on imaging, on a MRI, on a CT, on a sonogram. There are fluctuant masses. Those are cases that are treated with IV gentamicin and IV clindamycin. And the gentamicin is for the gram negatives, and the clindamycin is for the gram positives. So these are addressing the secondary invaders. See, the cefotetan and doxycycline is looking at the gonorrhea and chlamydia, whereas this is looking at the gram negatives and the anaerobes. And we'll come back to that after the break, and I'll show you some pictures. But in the meantime, why don't we take a 10-minute break and see you in 10. Okay, here we are back talking about PID. This is from the CDC, the Center for Disease Control, ceftriaxone plus doxycycline, metronidazole. You see here where they say with or without metronidazole. And I figured, hey, I would rather go ahead and do it and cover it than not. Okay, cervicitis we've already talked about. This is in the presence of mucopurulent cervical discharge or a friable cervix. That's the CDC criteria for a clinical diagnosis of cervicitis. The mucopus and the friable cervix. And that will be treated with the cephalosporin and the azithromycin. Okay, acute salpingo-oophoritis. We already talked about the minimal criteria, which are here. They're in your notes on page 208. That's all you need. There are supportive criteria, and here they are on page 208 as well. And remember, it is a clinical diagnosis, a clinical diagnosis. All right. The outpatient criteria, inpatient criteria, we talked about that. The inpatient, cefotetan plus doxycycline. We already talked about that. Okay, let's look at tubo-ovarian abscess. Now, you typically say if there is an abscess, you're going to drain it, right? You usually say you're going to drain it. This is not a typical abscess. It is not your typical pus pocket. What it is, let me come back here. It is a mass, an inflammatory mass, which involves the tubes and the ovaries and the omentum and the bowel and the uterus. And so typically the way this is handled is not with drainage, but is with antibiotics. And this is where we would use a clindamycin. Clindamycin is directed primarily at the anaerobes, and gentamicin, which would be directed at the gram-negatives. So those are your secondary invaders. The primary invaders, gonorrhea and chlamydia. The gram-negatives and the anaerobes would be the secondary invader. In other words, the damage is already done, and now the way is prepared for these secondary guys to come in. So over here, this is a ultrasound of a tubo-ovarian abscess before the treatment with the antibiotics, and you can see how it has shrunk way down. This is 3 weeks later. Now, if you're not getting a response with a severely, acutely ill patient, then you may need to do a exploratory laparotomy and do either drainage or a clean out. And that's a tough one. All right. Chronic PID. Chronic PID is really not well named. What it really should say is pelvic adhesions. Post-inflammatory pelvic adhesions. All right, we do the laparoscopy, and what do we see? Adhesions. Adhesions. Can you see how this tube is so kinked? It would be a surprise if she could get pregnant. And the ovary is stuck down. When one organ moves, the other moves. And that's going to be painful. Again, you can see the adhesions. But look at the next picture. It's worse. How are you going to get rid of these adhesions? You know, the anatomy is almost undistinguishable. I think this is probably the uterus over here. This may be a tube over here. But can you lyse these adhesions? Best of luck. See, this is what we call a frozen pelvis. How do you treat a frozen pelvis? And this is where you may need to do a TAH BSO. You got to clean all this out. If the main concern is pain where she can't function, bad news. Look at the adhesions here to the posterior uterus. Now, I don't even know what this is over here. This white area looks like it may have the ovaries involved there. Adhesions, 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 adhesions all over the place. Now, this is the right upper quadrant. And these are adhesions in the right upper quadrant. And these are, let me see if I can get my hand in here. What kind of adhesions are these? I'm trying to play the violin. These are Fitzhugh-Curtis. That's trivia, isn't it? I mean, but if you see it, you know it. That's what it is. And what this was caused by was a very purulent salpingo-oophouritis. The pus came up into the upper abdomen, caused a perihepatitis. It wasn't a hepatitis which is in the parenchyma of the liver. It's just on the outside of the liver. So this would be a Fitzhugh-Curtis. This would be a Fitzhugh-Curtis. And you can appreciate how this would be painful. Okay, so that is PID. Fix this someplace in your brain. All right, another cause of pain in women of reproductive age is primary dysmenorrhea. Dysmenorrhea. What's dysmenorrhea mean? What's dys? Dys is pain. So if you have dysphagia, dyspareunia, dysmenorrhea, it's pain. Pain with menses. Okay, let's look at our case here. 15-year-old girl comes to the outpatient office with severe menstrual period pain that started 6 months ago. It is pain with the menstrual periods. Onset of menarche was age 13. She is now 15. So how old was she when this started? 6 months ago, so 14 and a half. So from age 13 to age 14 and a half, she didn't have any problems with the pain. That's interesting, and we'll come back to that. The pain can be so severe she's unable to attend school or carry on normal activities. So it has a lot of morbidity to it. She describes it as cramping in nature. That is an important point. It is cramping, and we'll look and see why is there cramping. It is associated with nausea, vomiting, and diarrhea. That's interesting. Why is there GI tract involvement as well? With her menses, when they're gone, when they are completed, the pain is gone. She's not sexually active. General exam is normal for her age. Pelvic exam is unremarkable. Okay, what is the issue here? The onset is typically 2 to 3 years from the onset of the first menstrual period. The first menstrual periods are without ovulation. They are anovulatory. There is no corpus luteum. There is no progesterone. Secondly, the pelvic exam is normal. What does that mean? It means that the uterus is midline, movable, non-tender. There are no adnexal masses or tenderness. There is no uterosacral ligament nodularity on a rectovaginal exam. There's normal anatomy. That's different from secondary dysmenorrhea. We'll talk about that in just a bit. The main symptoms are cramping along with nausea, vomiting, and diarrhea. And what causes this is an exquisite sensitivity of the smooth muscle to prostaglandins, which are released from the endometrium. Remember, I talked about this on the first day, and we'll talk more about it tomorrow, that when you have a progesterone withdrawal bleed, You have spiral arteriolar spasm, necrosis, release of prostaglandins. And these young women have such a high sensitivity that they get cramping of the uterus that causes ischemia. They get cramping of their upper and lower GI tracts, leading to nausea, vomiting, and diarrhea. If the problem is an exquisite sensitivity to prostaglandins, there's a number of treatments that we could use. We can suppress prostaglandins with prostaglandin synthetase inhibitors, NSAIDs. The other thing is we can prevent the progesterone fall. Because if you don't have the fall in progesterone, you don't have the spiral arteriolar spasm. So you could give continuous progestins, or just for ease of prescription, you could give estrogen progestin oral contraceptive pills. But this is the ideal. Let me show you a picture. This is from my high-yield OBGYN book. When a woman becomes ovulatory, she will have a corpus luteum at the site of ovulation. The corpus luteum makes progesterone. If there is no pregnancy, what will happen? The corpus luteum starts to regress, progesterone levels fall. When progesterone levels fall, we have spiral arterial constriction. That leads to necrosis and release of prostaglandins. The prostaglandins cause smooth muscle contractions so strong that they cause ischemia, and ischemia causes pain. Now, if you remember when we talked about obstetrics, a good quality contraction generated 50 millimeters of mercury pressure within the uterus. These young women have had catheters put into their uteruses and measure the strength of the contraction with these balloon catheters. And they're measuring 100 millimeters of mercury, 150. So these young women are in labor, so to speak, for many days because of this uterine ischemia and contraction. So we can either suppress the prostaglandins and give continuous progestins, either MPA or oral contraceptive pills. So if we have pain in the heart because of ischemia, we call it a heart attack. Would it not be reasonable to call this then a uterine attack? So these uterine myometrial fibers contract so strongly they cause ischemic pain. All right, that is primary dysmenorrhea. Onset within 2 to 3 years of the first menstrual period. Pelvic exam is totally normal. Medical, not surgical treatment. Okay, let's look now at secondary dysmenorrhea. Secondary dysmenorrhea has its onset usually in the 20s or 30s. It is not related to anovulation, and there is typically some abnormality on pelvic exam. When you think of secondary dysmenorrhea, you should think of endometriosis, you should think of adenomyosis, you should think of chronic PID. We've already talked about chronic PID, we've talked about adenomyosis. Let's talk about endometriosis. Pelvic pain, you should think ectopic. We've talked about that. Appendicitis, surgeons will talk about that. PID. The big one that we need to talk about is endometriosis. Here's our case, page 211. A 34-year-old woman complains of dysmenorrhea, painful menses, dyspareunia, painful intercourse, and infertility for 2 years. She had used combination oral contraceptives from age 25 to 30. Pelvic exam reveals a 5-centimeter cul-de-sac mass along with uterosacral ligament nodularity and tenderness. Okay, what do you think this 5-centimeter cul-de-sac mass is in this young woman? Well, she's not young, kind of in the middle here. This is most likely, let's see if any of you get it, an endometrioma. Endometrioma. What is the most likely location for endometriosis? It is in the ovary. So a chocolate cyst, exactly. All right, don't write this down. I'm just trying to make my point. This is a serious problem. 5.5 million women in North America, 75% of chronic pelvic pain, 85,000 hospital admissions a year, and 40% of infertile women have endometriosis. All right, I've given you this handout. It's got the 4 significant slides which are on here. So you don't need to be writing and scribbling it down. You already have it there. All right, the first thing is, what are the symptoms? Bilateral pain. Pain with what? Pain with menses, dysmenorrhea. Pain with sex, dyspareunia. Pain with bowel movements, could be from rectal endometriosis. This is called dyschezia. So it's bilateral pain. Is it going to be chronic or is it going to be acute? And it is typically chronic pain. So it's important to differentiate between chronic pain and acute pain. What do you find on pelvic exam? There is bilateral tenderness, similar to chronic PID. Similar to chronic PID. And we make the diagnosis the same way. For PID, chronic PID is a laparoscopy. With endometriosis, the way you nail down the diagnosis is also laparoscopy. So bilateral tenderness, a fixed retroverted uterus. Now, the majority of women will have an anteverted uterus. It'll be tipped anteriorly. 15% of women will have a retroverted uterus, but it shouldn't be fixed. It shouldn't be immovable. Why is it fixed retroverted? Because it's adhesions which is holding it down. It's adhesions. The uterosacral ligament nodularity is a scar tissue on the uterosacral ligaments, and we'll look at a picture of that. The location of the endometriosis, ovary, cul-de-sac, uterosacral ligaments, and the rectosigmoid. What is it that results in endometrial glands and stroma being outside of the uterine cavity? When we have endometrial glands and stroma in the wall of the uterus, we call that adenomyosis. But when it is outside of the pelvic, out of the uterus, it is endometriosis. The best evidence suggests that for a lot of women, it is retrograde menses. Instead of the menstrual flow coming down through the cervix and out of the body, it goes up into the fundus of the uterus, out the tubes, and then spills out into the peritoneal cavity. So let's look at this picture right here. The menstrual flow goes this way instead of this way. Now, what organ is located right here? What organ? The ovaries. So it makes sense, if you think of it retrograde menstruation, that the most likely location is going to be in the ovaries. Now, if you look at the cul-de-sac laparoscopically, this is a woman who has a clean cul-de-sac, no blood. This is a woman who's on her menses. I think there's probably quite frequently blood in the cul-de-sac with retrograde menses, but not all of these women are going to get endometriosis, and it's not entirely clear why. But now, some of the endometriosis is, you can't explain it by retrograde menstruation. It can be in the appendix, not on the outside of the appendix. It can be in the appendix. It can be in the lung. And when a woman has her menstrual period, she coughs up blood. So there's a lot of places it can be, but most of it is in the pelvis and would fit a retrograde menstruation. Where is it found? Most likely on the ovary. Here we have the uterosacral ligaments. This is the rectosigmoid, and this is the cul-de-sac down here. Now, this picture is really not accurate. Let me see if I can demonstrate this. Do you think the uterus and the fallopian tubes are stretched out like this? I don't think so. I think the uterus and the tubes and the ovaries are usually over here behind the uterus, more kind of like this, right? They're behind. So when the menstrual flow comes down, it doesn't go way out here. It comes down onto the uterosacral ligaments, down onto the rectosigmoid, down into the cul-de-sac. Okay, this is an antebird uterus. The fundus is up here. The cervix is down here. You're going to see this on a speculum exam very easily. If you have a retrobird uterus, notice the cervix is way anterior. When you put your speculum in to do a speculum exam, on a retrobird uterus, it's hard sometimes to find the cervix. And here you are looking in with a speculum, and you can't find the uterus, and you're poking around, and the patient says to you, "What are you doing? Do you know what you're doing in there?" And you feel like an idiot, right? Well, what you do if you can't find the uterus, there's two things. You can do what it's doing here. Put your finger in the vagina and see if you can feel where the cervix is. The other is to tip the speculum so it's going up this way instead of down this way. But my point is, if the uterus is retroverted and you can't lift it up, it's probably because of adhesions from endometriosis. Now, this is interesting. Autoimmune diseases are more common with endometriosis. Systemic lupus, multiple sclerosis, rheumatoid arthritis, Sjogren's disease. It's more than just the retrograde menses, I think. There are cytokines, there are interleukins, which seem to be associated with endometriosis. Could this be an autoimmune disease? I wouldn't be surprised if we find that in a few years. Now, this is a laparoscopic visualization of a totally normal pelvis. This is beautiful. Uterosacral ligaments right here, cul-de-sac down here. This is the round ligament here. This is the tube. Can't see the ovaries very well. But compare now this picture and this one. You see all of the endometriotic implants on the ovary. There's something here. 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 Typically, it is dark, black or blue, and you can see the scarring. Sometimes these are called gunpowder burns. And here they are. Sometimes they're more reddish, and this can be seen with adolescence. Sometimes it's clear, and you don't even, it's much harder to see. But laparoscopy is what you would do to make the diagnosis. Now, look at this uterus here, and can you appreciate why it is fixed? Because look at all the adhesions which are here. And this is a tough one to dissect through. Okay, what do you do for endometriosis? Well, what if she could get pregnant and she would have high levels of progesterone for many months? See, when you have the fall in progesterone, it causes the spiral arteriolar spasm, the release of prostaglandins, and the bleeding. The problem is that many patients who have endometriosis can't get pregnant, have infertility, even though anatomically the tubes look to be normal. So if you can't have a real pregnancy, how about a pseudo-pregnancy? A pseudo-pregnancy could be because of continuous medroxyprogesterone acetate, continuous progestins, to prevent that fall in progesterone and the spiral arteriolar spasm. You could use continuous oral contraceptives, which contain both estrogen and progestin. Now, does she need the estrogen? No. But the progestin would be easy to give just using oral contraceptive pills. The other thing you could do is to lower the estrogen level and see if you could get atrophy of these implants. You could use leuprolide, which is a GnRH agonist, which suppresses the FSH. As FSH is suppressed, what happens to estrogen goes down. Another possibility is to suppress the gonadotropins with subcutaneous depomedroxyprogesterone acetate. Depomedroxyprogesterone acetate. Jose asks, in order to get pregnant, would they need IVF? It's interesting that IVF doesn't work as well in patients with endometriosis. Okay, this is in your book, Medical Therapy, Pregnancy, but may not work because of infertility, pseudopregnancy, and pseudomenopause. Now, with a pseudomenopause, what kind of symptoms would the patient have if they have lowered estrogen? You would have hot flashes. You would have vasomotor symptoms. You know, that's not particularly fun to have that. And so sometimes they will use, with a leuprolide, what they call add-back estrogen. Okay, this is looking at dysmenorrhea using the green or blue here is oral contraceptive pills. This is placebo, and this is the amount of pain. And you can see that the pain goes down significantly, but it doesn't take it away completely. And this is the number of months after being on the medication. So oral contraceptives would be helpful. This is an advertisement for Depot Sub-Q Provera, which is a medroxyprogesterone acetate, which is used for the endometriosis. It's interesting when you look at the cost. What does the Depot Sub-Q Provera cost, and what does the Lupron cost? And you can see from a cost-effective standpoint, you're far better to use the Depot Sub-Q Provera than the Lupron. You can assess the degree of endometriosis lesions laparoscopically by using a staging device. You can see this is minimal involvement. We see a little bit more involvement here. You can see how heavy these are on the uterosacral ligaments, and this looks pretty heavy duty. So we can grade and stage the endometriosis. So this is primarily if you're doing studies and you want to compare patients who have similar degrees of involvement. Okay, we talked about medical therapy, pseudo-pregnancy, or pseudo-menopause. The surgical treatment is based upon, do we want to preserve fertility? Or if the pain is a primary issue, do we want to relieve the pain? So you can preserve fertility by lasering the lesions. I'll show you what those look like. And you can do lysis of adhesions if there is involvement of the fallopian tubes. The aggressive is to do a pelvic cleanout with a total abdominal hysterectomy and bilateral subpingual oophorectomy. But that would be kind of your last resort, because this is the most aggressive therapy and the highest rate of complications, and the most expensive too. All right. This is an endometrioma. Uterus over here, and you can see this is pretty good size. And this is where they get the name chocolate cyst. And this is an artist's conception of a enlarged ovary with this. This is the blood which has bled into this and which is now being degraded. So the chocolate is really the residual of old blood. Now, it's interesting. I've seen patients who have a huge endometrioma like this, and you can see there are areas of involvement all over the pelvis. No symptoms. No symptoms. And other patients who have minimal amount of adhesions and symptoms have a lot more. Now, this may explain some of that. When you look at the surface, here and here and here, they look all the same. But which do you think would have more of the pain? I guess this is a no-brainer. You'd expect much more pain here. So you could have a lot of these kind of surface lesions and have minimal pain, whereas this one, which has a lot of deeper involvement, you would have fewer lesions, but you'd have more pain. So I don't think we entirely understand endometriosis at this point. And we're somewhat dealing with the presentation rather than the underlying pathophysiology. Okay, so that is endometriosis. Okay, Steve, if you would get chapter 9 ready, that's going to be coming up pretty soon. Okay, adenomyosis we've already talked about. This is where you have endometrial glands and stroma in the wall of the uterus. Okay, I want to look at the various kinds of secondary dysmenorrhea, and they are in your handout right here. And I've summarized this for you. We've already talked about some of these, but I'll summarize it. Endometriosis, adenomyosis, leiomyomas, chronic PID, ovarian cysts. Endometriosis, painful, well, all of these have painful menstrual periods. So I won't mention that again. But there could be painful sex, painful bowel movements, dyspareunia, dyschezia. The uterus may be fixed and retroverted. We talked about that. There can be uterosacral ligament nodularity. And I looked at that, how that can happen as the retrograde menses happen. What is the treatment? We can use progestins to prevent the fall in progesterone, or we can lower the estrogen with GnRH agonists, leuprolide. Surgically, we can do adhesion lysis, or we can do hysterectomy. Adenomyosis. This is secondary dysmenorrhea, along with menorrhagia. Menorrhagia, heavy periods. Uterus on exam, soft, tender, uniform, enlarged. We talked about medical treatment, Mirena, IUD, and hysterectomy if you're going to do definitive treatment. Leiomyomas, firm, enlarged uterus. Let me just say that all of these causes of secondary dysmenorrhea have abnormal physical exam. With primary dysmenorrhea, normal pelvic exam. Okay, leiomyomas. Treatment, you can do a myomectomy if we want to preserve the fertility. You can do uterine artery embolization. Fertility may not be as good, but she keeps her uterus. You could do a hysterectomy and remove the uterus if fertility is no longer desired. Chronic PID, secondary dysmenorrhea, diffuse pelvic tenderness, cervical motion tenderness, adnexal tenderness from scar tissue. This is diagnosed by laparoscopy. Mild analgesics, we talked about that. If it is chronic pain, can't stand it, pelvic clean out. Ovarian cysts I included for completeness. I don't understand how ovarian cysts cause secondary dysmenorrhea, but the references said they do. We talked about ovarian cysts, typically unilateral, soft, mobile, tender pelvic masses, fluid-filled, round and smooth. Most of the time, they are functional. Observation, they'll go away if they don't laparoscopic resection. So when we look at the anatomy, endometriosis, you're going to have a fixed retroverted uterus with uterosacral ligament nodularity. With adenomyosis, it is a soft, tender, uniform, enlarged uterus. With leiomyomas, a firm, non-tender, lumpy, bumpy, enlarged uterus. Chronic PID, diffuse pelvic tenderness, cervical motion tenderness, adnexal tenderness, and ovarian cysts, unilateral, soft, mobile, tender pelvic mass. With primary dysmenorrhea, remember, there is a normal pelvic exam. It is not an anatomic problem. It is the exquisite sensitivity of the smooth muscle in the uterus and in the GI tract to the prostaglandins. And this is my wife and I in Alaska. And here you can see glacier, which is coming down into the Utah. All right. Let's go to chapter 9, fertility control. Okay, some forms of contraception are extremely effective. Some are very effective. Some are not so effective. And in your book, it's got this. The most effective intrauterine device, dipomedroxyprogesterone acetate injection, implants, sterilization. Very effective oral contraceptives, the estrogen progestin patch, the ring, vaginal ring. The condoms, the cervical cap, the diaphragm withdrawal are less effective. What is it? What is it that determines whether it is extremely effective or it is less effective? And I see compliance. Reka says that. Barrier is less effective. What else? Anybody got something more to add? Because I'm going to give you my answer in about 10 seconds. And controlling ovulation. Okay, look for this here. It is the number of decisions required. How many decisions to have an IUD? 1 every 5 to 10 years. How many decisions for a sterilization? 1 for your lifetime. For an implant, how long is the implant good for? For 3 years. Depo-Provera, every 3 months. So once you make a decision, you can forget it. How many decisions to use a condom, cervical cap, diaphragm, withdrawal? Every time you have sex, you better remember. See, the fewer decisions, the more it is removed from intercourse, the more effective it will be. And this is in your book. Okay, the ideal contraceptive characteristics are inexpensive, easy and simple to use, unrelated to the time of intercourse, freely reversible, free of side effects, readily available, free of cultural barriers. That doesn't exist. That doesn't exist. There is no perfect contraceptive. There are benefits, there are drawbacks, and you have to weigh them. All right, this is looking at the 3 main mechanisms for contraceptives to work. Prevent the sperm from entering into the cervical canal. The combination of steroid contraceptives will suppress ovulation. And so that's how they work. The intrauterine contraception used to be called the intrauterine device. Now it's also called the intrauterine system. They work by either decreasing sperm transport or preventing implantation. So these are the 3 main mechanisms in which contraception takes place. Barrier spermicidal. 16-year-old adolescent comes to the family planning clinic requesting contraception. She's heard about the diaphragm and wonders if it would be appropriate for her. What do you think? Good idea or bad idea? 16-year-old. Not a good idea. How many times do you have to make a decision? Every single time. Adolescents are not known for their discipline. However, there are advantages to the barrier spermicidal. 1 is decreased STDs. If you prevent the epithelium from touching the epithelium, and this is primarily with the condoms, you're going to get less STDs. That makes sense. Woman says, I don't want hormones going throughout my body. Then you say, I think we've got something for you, which has no systemic side effects. Now, disadvantages, One of these is HIV transmission is increased. And listen carefully because this is important. The spermicides, they attack the lipid membrane. If you have attacking the lipid membrane of the genital epithelium and you have an opening which occurs, HIV can make its way through into the systemic circulation. And that's how the genital ulcers increase the risk of HIV transmission. So it is the lipid membrane effect of the spermicide. So otherwise, it's not the issue. 20% failure rate is a big disadvantage for the barrier spermicidal. And this is primarily because of the human frailties. Honey, the moon is so beautiful. Or honey, I forgot my diaphragm at home. Oh, it will be okay this one time, right? Okay, you should know for the exam that the spermicidal agent, which is used almost 100% in these agents, is non-oxynol 9. Non-oxynol 9. It attacks the lipid membrane of the sperm and it breaks it down. That's how it destroys a sperm, by attacking the lipid membrane. But it can also attack the lipid membrane on the genital epithelium. So this is the most common barrier method used worldwide, the male condom. And one size fits all, right? Actually, that is an ultrasound transducer cover. But you could have, if you think you are bigger, get a Magnum model, or you can get a Snugger Fit model. They come in different colors. They are amazing in distensibility, the condoms. Amazing. They come in different flavors. They can come glowing in the dark. I tell you, the merchandising that takes place is amazing. Now, this is a female condom. This end goes into the vagina, into the cervix, and this is on the outer part of the body, like this. Now, you don't have to fit these because there's only one size, the female condom. Not used as much as they could be. They have definitely a lot of potential, but you can appreciate how this could interfere with the spontaneity of lovemaking. This is a diaphragm, and you see where it fits into the fornices, and you have to put into the dome of the diaphragm spermicide, and you can see it's put in right here. So the spermicide goes in the dome of the diaphragm, it fits in here, and it holds the spermicidal agent against the cervix. So if any sperm get in, it destroys it. So individual fitting is needed depending on the dimensions of a woman's vagina. Place it up to 2 hours before sex, but you need to leave it in for 6 hours after to make sure that the spermicidal agent is going to take care of any of those sperm which are left around. Now you can see how it needs to be snug, because with sexual arousal, the vaginal dimensions will change and it'll become bigger. So you have to have it snug, but if it's too snug, you could see how you could get a compression of the urethra and urinary retention. That would be a good board question. This is a cervical cap. It needs to be also individually fitted. You can leave this on for a few days at a time. Not used very much in the United States. I wouldn't use this diaphragm. I don't think it's going to work very well. So, condoms, vaginal diaphragm, spermicides. The active agent, non-oxynol 9. Okay, tell you what, why don't we take our last break before we get into the steroid contraception? So we'll see you in 10 minutes. Okay, here we are back for our last hour, and we're going to go to combination estrogen plus progestin, steroid contraception. There's a number of entities that we can look at. The oral pill, you're very well familiar with. 3 weeks on, 1 week of placebo. That's our typical oral contraceptive pill. There is now a formulation in which you take the pill instead of for 3 weeks, you take it for 12 weeks. And then you have a week of withdrawal bleeding. So you only have 4 periods a year. The IM injection is no longer available. This was a monthly injection, but there is a dermal patch called Ortho-Evra. We'll talk about that. There is a vaginal ring, which is known as Nuva ring, and we'll talk about that briefly too. So in your book, combination oral contraceptives, the ring, and the patch. All right, mechanism of action. This is in your book. And what we're looking at with steroid contraception is one of the mechanisms is at the level of the pituitary, it suppresses the LH surge. And this is on page 216. If you suppress the LH surge, you don't, so it also works on the ovary. It can also cause endometrial atrophy, and so you don't have implantation, which occurs, and the cervical mucus can become hostile. Now, when you look at these, the first two, suppressing the LH surge and suppressing ovulation, can be both estrogen and some progestin. But the atrophy and the hostile cervical mucus are only progestin. So that would be important to remember, okay? These two are both estrogen and progestin. These two are progestin only. This is estradiol in reproductive years, but estradiol is not absorbed orally. So the estrogen which is used in steroid contraceptives is ethinyl estradiol, not estradiol itself. The metabolic effects you should know. Estrogen can stimulate increased thrombosis, both venous and arterial. Now, estrogens lead to a healthy lipid profile. They increase HDL and lower LDL, but they do have a dose-related effect on venous thromboembolism. Progestins do not have any effect on thrombosis, but they do contribute to an unhealthy lipid profile. They lower HDL and increase LDL. So if a woman has a history of DVT, pulmonary embolism, stroke, don't use estrogen-related steroid contraceptives, but progestin is okay. The non-contraceptive benefits of steroid contraception. This is on page 217 in your book. Most of these are related to progestins. We just talked about decreasing primary dysmenorrhea. We talked about decreasing secondary dysmenorrhea with endometriosis. There is decreased anovulatory bleeding, or DUB, dysfunctional uterine bleeding. We'll talk more about that tomorrow. Decreases PID because the cervical mucus is changed and doesn't allow the ascending infection to go up. If there's decreased PID, there's decreased ectopic pregnancy because there's less tubal adhesions. There's also less iron deficiency anemia, breast fibroadenoma, rheumatoid arthritis, ovarian cysts, acne, a lot of non-contraceptive benefits. This is in your book. Okay, in terms of cancer, we talked about this. There's a 50% reduction in epithelial ovarian cancer with long-term 10 years or more steroid contraceptives. There is a 50% reduction of endometrial cancer with prolonged use of steroid contraceptives because it protects the endometrium from the unopposed estrogen stimulation. Colon carcinoma is decreased I don't talk about that. Hopefully the internal medicine people will do that. The best indications is that breast cancer, there is no difference, whether there's a family history or not, whether it's a high dose or low dose. Interestingly, cervical cancer occurs more in women who are using oral contraceptives because they don't have the protective effect of the barrier methods. So it's not that they increase cervical cancer, but they don't prevent like the barrier methods would prevent. So that's the main thing here. Okay, let's look at estrogen. When the early oral contraceptives were introduced, the low dose was 80 micrograms and the high dose was 150. Nowadays, today, the low dose is 20 micrograms and the high dose is 50. So you can see we've done a huge step in lowering the estrogen dose, in lowering the risks of thromboembolic disease. And it's important when you look at studies, are they old or are they new? All right, the 3 weeks on, 1 week off, you're well familiar with that. The failure rate increases as a body mass index goes up, particularly with the lower dose. And here you see the 3 weeks on in red and the 1 week, which is the placebo, which is off. Now, there is a new contraceptive combination which has 24 days on and 4 days off. And the name of this is Yaz. Yasmin has 21/7, like the usual contraceptives, but Yaz is 24/4. Now, what do you need to know for that? Yaz is has as its progestin drospirenone. That is a unique progestin. It has less acne, and it also has less mineralocorticoid activity, and so less retention of water. Now, the Yaz is approved. We'll talk more about that later. Here is a standard 21/7. Here is a 24/4. So 24 days of the steroid and 4 days off. And this is what you would use for PMS. There's always a concern about venous thromboembolism. And yet, when you look at this, you've got to ask, what is the risk of thromboembolism with pregnancy versus the risk with the pill? And I'll show you that in just a minute. There's the extended cycle oral contraceptive pills. Instead of having a week off every month and you have 13 periods a year, you take it for 3 months and then have your withdrawal period. So you have 4 only withdrawal periods a year, only 4. So every season you have one. One in winter, one in spring, one in summer, and one in fall. Just 4 periods a year. Fewer periods, more possibilities. That's the advertising. Now, this is looking at the mortality rate per million women of reproductive age. What is the likelihood of dying with no oral contraceptives, with oral contraceptives, and pregnancy? This is from venous thromboembolism. And you can see, sure, there is a higher rate with oral contraceptives. Much better than if you were pregnant. So you always need to ask, what is the risk of it, the risk not of it? This is Tylenol poisoning. There are far more women who die from the effects of Tylenol on their liver than with oral contraceptives. They even have oral contraceptive pills that you take continuously. This would be, for instance, with endometriosis, called Librel. No periods at all. Continuous use. Okay, let's look at the vaginal ring. The name of the vaginal ring is called Nuva ring. And the patch, the skin patch, is Ortho-Evra. The Nuva ring looks like this. It is about 2 inches, 54 millimeters in diameter, and it is 4 millimeters thick. So it's very soft, very pliable, and it is placed in the vagina. It doesn't have to be over the cervix, anywhere where it's in contact with the vaginal epithelium, and it will then absorb the released estrogen and progestin. You put it in, leave it in for 3 weeks, take it out to have your withdrawal period, and then do it over and over, 3 weeks in, 1 week out. Now, this is interesting when you look at the estrogen exposure with the Nuva ring versus the standard oral contraceptive pills. It's only half of the risk. So it's expected that there would be fewer side effects. And when you look at the blood levels of the oral contraceptives, which you take every day, and the reason you take it every day is because the level falls. But can you see with the ring how stable it is? And so you have less exposure to estrogens. Then there is the transdermal patch, ortho-evra, goes on the upper arm or the buttocks, like this. There's 3 patches, week 1, week 2, week 3. Here you see week 1, week 2, 3, and then you take it off and you have your withdrawal period. Now this is the level of estrogen, the ethinyl estradiol with the contraceptive patch. And you can see it's quite a bit higher than with the ring. In fact, if we compare them, let's look at this. This is the pill, combination pill, estrogen levels. This is the patch, and this is the vaginal ring. Now, I'm going to draw a horizontal line at 20 micrograms. Which of these has the highest exposure to estrogen? The patch, right? Which is the second? It's going to be the pill, and the lowest exposure would be the vaginal ring. I think we should use the ring a lot more, because the other thing is this is not absorbed through the GI tract. These two are absorbed through the skin, so they avoid the first pass through the liver, so they don't stimulate the clotting factors as much as they would if they went through the liver by absorbed from the GI tract. Even the patch, however, if you look at what about 50 micrograms, which is much lower than we used to have to begin with. Okay, the progestin-only steroids. We have the oral daily mini pill, which has been used for many years. The mini pill has to be taken the same time, every day. You don't have any time off. Its effect is primarily on the cervical mucus. It does not suppress gonadotropins. Now, the depomedroxyprogesterone acetate, the Depo-Provera, that is IM every 3 months. That does suppress the FSH and the LH. The subcutaneous implant used to be called Implanon. I need to change this. It is now called Nexplanon, and I'll show you a picture of that in just a minute. This you put under the skin of the forearm, and it's good for 3 years. The morning after pill is Plan B. If Plan A fails, what do you go with? Plan B. This is levonorgestrel. We'll talk about that. And then the Mirena is a IUD, which has levonorgestrel in it, and I'll show you that as well. So progestin-only oral contraceptives, progestin-only injectables, and the subcutaneous implant is Nexplanon. The mini pill, notice, every day, you don't have a holiday, because you don't want to lose that effect on the cervical mucus. You see, if you take combination oral contraceptive pills, you suppress gonadotropins. If you miss a day or two, no big deal, because the hypothalamus pituitary doesn't come back right away. But with the mini pill, every day. The implant is called Nexplanon. It is about the size of a match, a single rod of etonorgestrel, and you put it under the arm with this applicator here. You need to have special training. It only takes a minute to put it in. If you want to take it out, you have to find it. It is pretty easy to feel. Removal time, 4 minutes. So that's Nexplanon. It has barium in it, so if you take an X-ray, you can see. But it's good for 3 years. The IM injection, depomedroxyprogesterone acetate, or Depo-Provera is every 3 months. She can take the pill 1 day at a time, or spring, summer, fall, and winter. Why isn't that romantic? Depo-Provera. Now, you should know the side effects of Depo-Provera. Irregular, unpredictable bleeding. You see, you don't have the estrogen to stimulate the endometrium. So you have endometrial atrophy, which can lead to irregular bleeding. Also, it can suppress the gonadotropins, and you can have a prolonged return of fertility. It may take a few months before there is a return of ovulation. The other thing is it suppresses both FSH and LH. The LH surge you want to suppress because you don't want to have ovulation. But if you suppress FSH, what happens to estrogen levels? Estrogen levels will come down. What happens to bone density as estrogen levels come down? It also decreases. Now, this appears to be a reversible phenomenon, and so it is probably okay. But you should know this for the exam. The other is weight gain. 15 pounds of fluid if you use it for 5 years straight. So it's a single injection once every 3 months. Morning after pill is Plan B. It is a one-step. It is a single tablet, 1.5 milligrams. Sometimes it is called the emergency contraceptive. If Plan A fails, what plan do you go for? Plan B. I chose a condom, but it broke. Now I have a second chance. Plan B, when things don't go as planned. Now, let me stop. How does Plan B work? It may change the ovulation. It may prevent the sperm migration. Some people think that it prevents implantation of the blastocyst, and so it destroys a human being. I don't personally believe that, but that is what some people say. And so they say this is an abortion, not really contraceptive. This is the Mirena IUD. The old term was intrauterine device. Now it is called intrauterine system because it is not just an inert device. These release medications. And in the case of Mirena's, it releases levonorgestrel. This is the shape of it. This is the capsule that contains levonorgestrel. You can see it is released directly into the endometrial cavity, and it has a number of mechanisms. I want you to see the old IUDs. This has all kinds of different ones. And you see how they're white? They're just plastic, inert plastic. Now, this is a copper one right over here. But this is the Lippes loop, and I want to show you a picture of that so that you'll recognize it if you see it again. Okay, how many IUDs are available in the United States? This is a copper, and copper decreases sperm transport. And you can see it's got copper here and here and over here. This is good for 10 years. This is a Mirena, good for 5 years. Just recently, there's been released a newer, smaller levonorgestrel releasing intrauterine system, and it is called Skyla. So now we have the Paragard, the Mirena, and can you see the Skyla looks almost identical to the Mirena, but it's smaller. The Paragard is good for 10 years. The Mirena is good for 5 years. The Skyla is good for 3 years. So very recently been, as of January 2013. And you can see the size on somebody's hand here. Decreasing sperm transport, and this is the copper IUD here. And that's one of the main mechanisms. This is the levonorgestrel containing Mirena, and it releases over time the levonorgestrel. You pull the arms back to place it in the uterus, and once it gets in the uterus, the arms will pop out and it will form a T shape, which will prevent, hopefully, the expulsion. So it sits in the uterus like this. The string comes out so a woman can put her fingers in her vagina and feel the string to make sure it is still there. This is the string. It is a monofilament. Does it cause pap smears to be abnormal? No. Here you can see the squamocolumnar junction, right? And here is the T-zone. Would you like to be confident for today, tomorrow, and the next years? Levonorgestrel intrauterine system. That's the new term you should be familiar with. How does it work? It causes endometrial atrophy because of the effect of the progestin. It decreases sperm transport. And the progestin also thickens the cervical mucus to make it less likely that sperm can get up. So there's a number of different mechanisms that this uses. Skyla is basically the same. Now, this looks at the bleeding days per month with the copper and the levonorgestrel Mirena. And many women with the Mirena will stop having periods at all because of the effect of progesterone on, or the levonorgestrel on the endometrium. This is looking worldwide at IUD use. 15% of women. In Asia, it's almost 20%. You can see it's quite high. In North America, it's less than 1%. And this is because it has got a bad reputation because of the Dalcon shield, which was alleged to have caused infertility by causing PID. That was never proven, but I think we should use the IUD a lot more because it has as good a pregnancy prevention as does the sterilization. Now, the mechanism of action, this is on page 218. I've alluded to some of this already. Decreasing sperm transport, increasing tubal motility. And the idea is you want to have the sperm, when they get together with the egg, are not in sync. And so fertilization doesn't take place. Decreased implantation if you have a inflammatory response of the endometrium. Sperm and blastocysts destroyed. That is the concern about people who believe that personhood begins at conception. And with the levonorgestrel, cervical mucus is altered. So those are on page 218. You should know those. Contraindications. Okay, I'm going to look here. This is in your handout. Absolute contraindications for the intrauterine contraception and the steroid contraception. Obviously, if you're pregnant, it's beside the point to use an intrauterine contraception. Pelvic cancer, like endometrial cancer, cervical cancer, any vaginal bleeding. The big one to remember is salpingitis, PID. Do not put an intrauterine device in a woman who has PID. Not a past history of PID, but who has PID currently, because you're going to push bacteria up into the uterus. Now, steroid contraception, if she's pregnant again, is beside the point. Acute liver disease is an absolute contraindication because the woman gets rid of the steroid contraceptives through her liver. If her liver isn't working well, the levels can build up too high. Vascular disease, this is a concern with the estrogen containing. If there is a history of emboli, deep venous thrombosis, cerebrovascular accident, systemic lupus erythematosus, then you don't want to use the estrogen. But progestin should be fine. And obviously, if there is a hormonally dependent cancer, breast cancer, now I can't imagine you have endometrial cancer and you leave the uterus in. Why would they even put that there? But there it is. This is interesting. The continuation rate is when a woman starts a contraceptive method, what's the likelihood that she'll continue using that 1 year later? And what is interesting is the lowest of these is the Depo-Provera. Barely half of the women will continue using it. And the biggest concern for that is because of irregular bleeding. The pill, the ring, and the patch, you can see, are pretty well about the same. But the highest continuation rates are the intrauterine contraception, the Paragard, and the Mirena. What do you do if the tail of the intrauterine device cannot be visualized? You can't see it with a speculum exam. Then you need to try to find the tail with a probe. And here you can see the tail has been pulled up into the uterus. And it's kind of like a little crochet hook. You put it up into the uterus and see if you can pull it down. Now, it's still working, but you don't know if it's there because you can't see the tail. What if the imaging shows that the ultrasound, I'm sorry, if you can't find the tail with a probe, then what if the imaging with an ultrasound or X-ray shows that the intrauterine device is not in the uterus? Now what do? And here you can see this is almost perforated completely. This is the uterosacral ligaments. This is the cul-de-sac over here. The likelihood of perforation is highest at the time of insertion. It is the time of insertion. Okay, it's not in the uterus. Where is it? You may need to get an X-ray to see if it is in the abdomen. Here you can see a T-shaped copper IUD, clearly not in the uterus. So now what do? You got to do a laparoscopic removal. Now here you can just barely see the tail. Can you see that there? But they were able to find it and pull out this copper IUD. Now here you can see the Mirena. It's in the same orientation as here. And you can see the capsule. Can you see how the omentum tries to engulf it and protect? And this is a Lippes loop, which is almost completely surrounded by the omentum. Okay, another question. The IUS, intrauterine system, is in the uterus. Pregnancy test is positive. What do? Take it out or leave it in there? Take it out. If you don't take it out, you have an increased risk of spontaneous abortion, up to 50%. So take it out. Just grasp the string and give it a tug. Now, if the uterus, if you don't take it out and the uterus starts growing, it can actually carry it up into the uterus and you won't even find the tail. Now, will the baby come out holding the intrauterine device? No, there's no way, because it's going to be between the uterine wall and the membranes, and the fetus can't get access to that. So that's not an issue. How about periodic abstinence? This is where you avoid sex when the woman's fertile period is, and so you time intercourse only when she's not going to be fertile. That's not an easy thing to do, because it relies on predicting when ovulation occurs. That's not always easy. Now, you could use a basal body temperature. You can see this is the basal temperature here, and now it's going up. Is intercourse okay? Once ovulation has occurred. You see, the egg is fertilizable for 12 to 24 hours. The sperm is capable of fertilizing for 24 to 48 hours. So let's say you wait for 2-3 days after the temperature goes up. Are you okay? If the egg was ovulated at that time, then probably you are. So the basal body temperature chart can be used. Then you can also augment this by looking at the cervical mucus. When it is thin and watery and stretchy, you know it's estrogen dominance. You know that you don't have ovulation yet. But when the cervical mucus changes from thin and watery to thick and sticky, you know that's a progesterone effect, and you must already have ovulation. Now, this is a little device that looks at what is the possible fertile period, what is the possible time for menstruation, and when is the infertile period. So the idea would be that you want to avoid intercourse during this period of time and probably over here. I'm sorry, it's okay to have intercourse over here, but not over here, not during the fertile period. Now, these are cycle beads. They cost $12.95. And you put this little ring. Can you see the ring right here? The ring on the red bead. That is the first day of your period. And if you have 21-day cycles, when will you ovulate? On day 7 or 8. See? So you have day 1, 2, 3, 4, 5, 6, 7. Okay, stop. On the white beads, you don't want to have sex. So how many days do you have to avoid sex? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Honey, I can't wait so long. Right? Anyway, this is the cycle beads. When you look at various forms of contraception on their cost effectiveness, very cost effective down here, not very cost effective over here. So what are the least effective? Cervical cap, sponge, female condom, spermicides, diaphragm. That's up over here. The most effective is the copper T IUD. Now, when you look at sterilization, this is a female tubal ligation. This is a male vasectomy. Which is most cost effective? The male or the female? Vasectomy. Okay? Gentlemen, you notice this? When the time arrives, I hope that you will step forward and you will say, honey, you have done your part. Now it is time for me to do my part. What do you say? Folk methods. These are methods that seem like they should work, but they're really not very effective. Coitus interruptus, postcoital douche, prolonged lactation. Coitus interruptus. This is where the man pulls his penis out of the vagina before ejaculation. The advantage is it's inexpensive. It is readily available. Of course. The disadvantage requires discipline. This is the time you need to come apart, not stay together. And that's not what you want to do. You see, the other thing is semen can be put into the vagina prior to ejaculation. And once they get into the cervical mucus, they're gone. So does it work? Sometimes, but not very predictably. And here you can see he is pulled out. I'm a product of the pull-out method. Postcoital douche. This is the idea that you flush out the vagina with whatever to get the sperm out. Does it work? Well, again, how long does it take for sperm to get to the cervical mucus? And this is the time you want to jump out of bed and start flushing around. These are postcoital douches. You can buy these over the internet. This has been available. This was 150 years ago. The whirling spray syringe for women. Does it work? Well, this is a study looking at how long does it take from ejaculation for sperm to get to the cervical mucus to get into the fallopian tube. And you can see within 2 minutes, even 90 seconds, they're in the cervical mucus. And once they're in the cervical mucus, you can't get them out. That's the problem. Steve, if you would have the next chapter available, because I think we may get to chapter 10. Lactational amenorrhea, women who are breastfeeding tend to ovulate later. And I showed you this picture before. What's the percentage of women ovulating who are breastfeeding versus not breastfeeding at 3 months? And you can see that 90% of women who are breastfeeding do not ovulate. But 85% of women who are not breastfeeding will ovulate. So breastfeeding is good for a period of time, but I wouldn't wait more than 3 months. Okay, sterilization, male and female. 38-year-old Multipra has completed her childbearing, requesting sterilization. All 3 of her children were delivered vaginally. No medical problems. She's in good health. Unremarkable exam. Do you think it's okay for a 38-year-old woman who has 3 children to have a sterilization? Yeah. The question is, we have many women here, at least in California, 20 years old, 4 children, 1 a tubal ligation. What do you think of a 20-year-old? I'm not sure that's such a good idea. You can do all kinds of different methods, and this is in your book. Tubal ligation failure rate 1 in 200, vasectomy 1 in 500. World Vasectomy Day. Balls on the line. And here is this guy who on television volunteered to have a vasectomy to encourage men to have it done once they have finished their childbearing. Microsurgical vasectomy reversal. This is a billboard on the Strip in Las Vegas. Money back guarantee. See, what they say is our guarantee, if sperm is found at the vasectomy site, we guarantee sperm in the ejaculate within 6 months, or we will redo the procedure free of charge. They guarantee that they can do the plumbing. But is that all that's needed? And here's the problem, that 50% of men who have a vasectomy will develop anti-sperm antibodies, and they will attack either the head or the body or the tail of the sperm and agglutinate. So even though you have the vasectomy reversed and the tubes are working, you may not be able to have children. So don't have a tubal ligation unless you are really done. Really done. Okay, you ungrateful brat, I had my vasectomy reversed to give you life. This is Papa talking to Junior. And do you think Junior will ever appreciate all that Papa has done? Hardly. This is a filshy clip. If you want to do the least damage on a tubal ligation, let's say you have a 21-year-old, 22-year-old who's got 4 children and wants a tubal ligation. She's old enough to vote. She's old enough to go into the army. Do them as little damage as you can. Use a clip. Don't do the burning, the coagulation, because that can really destroy and make it much more difficult to reverse. This is a hysteroscopic placement of this spring into the isthmus of the tube, right here. And you see it causes scarring. It's called Essure. And it can be done as an outpatient procedure. Costs about $400 or $500, but that's pretty good for a lifetime sterilization. They recommend getting a hysterosalpingogram to make sure the tubes are completely blocked. This is about the size of this little spring, which irritates the tube and causes a scar. Okay, I put this into your handout. Let's go through. They're going to ask you questions on the exam about what would be the best contraception for a certain patient. You need to know your impulsive. Is she mature or is she immature? When you look at methods of reversible contraception, if they're used perfectly, the failure rate is less than 5%. Notice what happens when the passions of the moment enter it. See, withdrawal and rhythm, the diaphragm, the condom, they go out of sight. So if you have a patient who is not disciplined, who is immature, don't suggest withdrawal, rhythm, diaphragm, or condom. You want to use some of these which show very little change because they're only once every few months, like for instance, the implant. Use those kinds of methods. Okay, let's look at basic principles. This is in your handout. First, estrogen plus progestin steroids, ideal for healthy women, especially young women, teenagers. We talked about all of the things which are so helpful, about less acne, less iron deficiency anemia, less dysmenorrhea, all of that stuff. Prevention against endometrial cancer, ovarian cancer. Who should get progestin-only steroids? Woman who is lactating, because if you give estrogen, you can sock it to the milk production. If she can't use estrogen because she's had thromboembolic disease. A smoker over age 35 is better off pregnant than to be on the estrogens. So don't use that in these people. The IUD, the intrauterine system, ideal for a monogamous multipara with no salpingitis. Now, monogamy, what does that mean? In the United States, we have this, I have one sexual partner today, I have another sexual partner tomorrow, I have monogamy one day at a time. Right. We're talking about lifetime monogamy here. That's the ideal candidate. Okay, barrier. Who should use barrier method? Motivated, because remember, you've got to use it every time. Women who have lower fertility, they're at the end of their reproductive years, it might be okay. They don't need a very effective form. And we talked about multiple sexual partners to protect against STDs. Natural family planning. The only benefit that I can see is for religious reasons. This is the time to ovulation. It takes a huge amount of discipline on the part of both partners. Sterilization. When you've completed childbearing, when you're done for sure, that would be the way to go. Okay. Healthy 17-year-old nullipera. I would suggest estrogen plus progestin, either the pill or the ring or the patch. But avoid the IUD because you're concerned about PID. Barrier methods, natural family planning, not a good idea. How about a married, faithful, compulsive 25-year-old gravid a tube, pair of two? Why, she could use anything. Everything is okay for her because she's got no contraindications. IUS, any estrogen, progestin, whatever, no problem. What if she's a married scatterbrained 25-year-old gravid a tube, pair of two? You don't want to have something that she needs to think every time she has sex. So that's where the intrauterine system, the patch, the ring. Certainly avoid any barrier method. Married, faithful, non-smoker, 40-year-old, gravid a three, pair of three. She could also use almost anything. I would avoid natural family planning because she may not be able to predict her ovulation as well as she gets older. And again, sterilization only for those who have completed childbearing. The risk factors for regret after sterilization are age less than 30. If she is being coerced into this by family, if she is in mourning, if she's because she lost a baby or had a fetal demise. See, when she recovers from that, she may want to change her mind. And the other is that there's medical indications. That she has diabetes and she's afraid of going blind, but she's got a lot of ambivalence. Those would be risk factors for regret. These are metal IUDs that I used to have on my white count. This is the copper, and this was given to me by a Mirena salesman. Okay, let's go on, Steve, to chapter 10 and see what we can do with human sexuality. Okay, this is an interesting picture. It was taken in Vancouver with the Olympic Games up there when they had a riot when the Canadian team lost. And here's this young couple. Amazing picture. Okay, human sexuality. Would you agree? Sex is not simple. If you think sex is simple, you are naive. It is very complicated. All right. Here's our case. A 31-year-old mother of 4 children has little interest in sex for the past year. One of the main complaints of women is decreased libido, decreased sexual desire. She says sex is painful, but she is able to experience orgasm occasionally. She has had no other sexual partners other than her husband. These problems are affecting her marriage. What do you think? Yeah, I had a woman come to me. She had a baby about a year before, and she said, as far as I'm concerned, if I never have sex again in my life, that's fine with me. I tell my husband, just go ahead and tell me when it's over. Could that be affecting her marriage? Yeah. Okay, why? She had a tubal sterilization performed after her last delivery 2 years ago. Do you think you have decreased libido with the tubal ligation? No. No evidence of that whatsoever. However, medications she is taking include thyroid replacement and fluoxetine. Any relationship there? Yes. The fluoxetine is known to decrease libido, SSRIs, selective serotonin reuptake inhibitors. So that's an issue. Okay, the sexual response cycle. We typically think of a linear sexual response cycle, which means you start with libido, you end with orgasm. And that is right here. You always start here, you always end up over here. And that, I think, is pretty true for men. But the evidence nowadays is that for women, it may not be linear at all. That women may have a circular human response cycle. They don't enter into sex because they have high libidos. Let's talk about that. Okay, here are the sexual response cycle components as described by Masters and Johnson. Start with excitement, go to plateau, then go to orgasm, and then you have resolution. So excitement, plateau, orgasm, and resolution. This is William Masters and Virginia Johnson. They were in St. Louis, Missouri, and they did landmark studies, laboratory observation of 700 men or women masturbating or during intercourse. And they did all kinds of physiologic studies, galvanic skin response, blood pressure, temperature, respirations, all kinds of stuff. They were criticized. How could you be so evil? And yet they gave us valuable information. They described the sexual response cycle as starting with excitement, going to plateau, orgasm, and resolution. In this order, both men and women. Helen Kaplan Singer was a psychiatrist in New York, and she agreed for the most part with them, but she said you've got to start with desire before you have excitement. So you have desire or libido, which leads to arousal, which is excitement and plateau, and then orgasm. However, Helen Kaplan Singer also believed that desire had to precede arousal. She believed that the end point of female sexual satisfaction is orgasm, and some of the best information suggests that may not be a big deal for women. Male and female identical, and there's a lot of evidence that that is not the case. If you should see on the exam this image or this image, this is from Masters and Johnson, looking at the female and male sexual response cycle. Excitement, plateau, orgasm. Now, women can potentially have multiple orgasms. Now, you see, this is a dotted line. This is a solid line. Many women could have multiple orgasms, but they don't necessarily want to. Men cannot have multiple orgasms. Excitement, plateau, orgasm, and then there is an obligatory refractory period. Women don't have a refractory period. All right, desire, libido. Dopamine is the pleasure hormone. When you eat for comfort, it's the dopamine that says, oh, great. When you take your shot of heroin, what is it that gives you the up? It's the dopamine. Dopamine stimulates libido. Serotonin inhibits it. So when we have SSRIs, when the serotonin reuptake is inhibited, the serotonin levels rise, what happens to libido? It goes down. Now, testosterone, the male, what is called the male hormone, is also in women. And that is needed. That sets a threshold for both men and women. Now, that leads to the parasympathetic nervous system, arousal, and excitement, and plateau. This is characterized physiologically by vasodilation and engorgement. There are very specific gender differences. Men will get an erection. Women will get vaginal lubrication. Very different, but the same mechanism. Plateau is really an intensification and continuation of the excitement. Okay, The excitement phase, engorgement. In men, we have an erection. What is it that stimulates men? What gets men excited? It is visual stimuli. What do you see on the walls of fraternity houses, of fire stations, of garages? Women not dressed very much or maybe no clothes at all. Why is that the case? Because men are excited visually. How about women? Are they excited visually? Not at all. I shouldn't say not at all. Much, much less. How long does it take for a man to get excited? I'll tell you. And he's ready to go. Okay, he's got an erection. How about in women? It is not the visual. And ladies, you need to know this. You look in the mirror, you think that you look too fat, too whatever. But when your man sees you, he says, honey, you are just perfect. And men, remember, it is not the visual, it is touch, it is a psychic stimuli. It is a relationship which is far more important in women. They take a longer time to get excited, much slower. And for women, it is vaginal lubrication. Now, what is interesting? This is Ann Landers here. Ann Landers used to write columns in newspapers across the country. People would write in and say, Dear Ann, I've got this problem. Give me some advice. Well, one time she put in her column, she wanted her readers to tell her what the answer was. And she asked, which is more important, foreplay or orgasm? There were 90,000 women who wrote in. 72% said foreplay was more important than orgasm. That's amazing. 68,000 men wrote in. How many of them thought foreplay was more important? Only 6%. Is there a difference between men and women? Bravo and viva la differenza. Okay, why don't we leave it at that? And we'll pick up on this tomorrow. And that will be our last day. And we will finish gynecology and have a good evening. Thank you, Dr. John, and thank you, Steve, and thank you all. Good night. Okay.